Okay, thank you all for attending, and thank you to those online. We've got participants who are dialing online, and this is being broadcast live and being recorded as well. My name is Helen from SAPMEA. And again, thank you for coming to today's education workshop, which is looking at working with military and emergency services personnel and their families. Okay, hang on. No, this doesn't work. Oh, there we go. It does work, sorry. Okay, so we are meeting today on the land of the Kaurna people, and before we start, I would like to commence with an acknowledgement of country. We acknowledge and respect the traditional custodians whose ancestral lands we are meeting here on today. We pay respects to elders past and present and emerging. We acknowledge the deep feelings of attachment and relationships of Aboriginal and Torres Strait Islander peoples to their country. Some quick housekeeping points to those online. If you do have experienced any technical issues, there is a FAQs in the chat feature. Your microphones are on mute, but we do encourage you to be interactive and submit your questions through the Q&A feature of the Zoom, and that is being monitored, and they will be answered through the session. An evaluation form will pop up immediately upon the close of the webinar. We do ask that you take the time to complete that, and certificates of attendance will be sent out to all participants online. Now, to those in the room today, we ask that you please keep your phones on silent. If you do need to go to the bathroom at all, it's just through the back door down the corridor on the right-hand side. And similarly, you will also be sent a certificate of attendance following the sessions. Now, this is the program for today, which you all have a copy of in front of you. There has been a last-minute change. Unfortunately, Dr. Ka Lung-Un has had a last-minute emergency and is unable to attend today. And due to short notice, we've not been able to confirm a replacement speaker. So that gives us a bit more flexibility in the presentation, in today's workshop for more question time and networking. But if there is anyone who is interested in the topic of physical injuries and would like further information, then please do reach out. We'll provide you with information, resources and connections. And to start, I would like to introduce Miranda, who's our first speaker to come up today.
Thank you very much, and good morning, everyone here in the room and also online. I don't have my speaker notes today, so you have to bear with me. I'm hoping I can do it without, but it's been a while since I've done some of these presentations, so let's see how we go. So my name's Miranda van Hooff. I'm an academic. I've been an academic with the university for 20 years. In 2019, I changed positions and came over to Military and Emergency Services Health Australia, which sits under the Hospital Research Foundation Group as the executive director there. So still doing pretty much what I was doing before in terms of running a research centre, but now we also have a service delivery arm and also a student training arm. So today I'm just going to be talking about service populations, and by service populations I'm meaning both military and emergency service personnel populations, and really trying to provide a bit of a framework and background around who is affected by mental health conditions in particular in these groups, and also why that might be the case and what particular risk factors we need to look for. So just to provide a bit of background, in Australia and internationally, both military and emergency services, and by emergency services I mean paramedics, police officers, firefighters and SES, are held in high esteem. So not only are they highly skilled, but they're trained specifically to look after us and protect us, to defend and protect our country and advance its strategic interests, to deliver initial response in emergency situations, and to assist us when we are exposed to the forces of nature in extreme circumstances. All of this places high demands on those who serve due to the potential for regular and repeated exposure to serious death or injury, as well as threats to life, safety and property. Additionally, both of these occupations at times require the service member to deal with very vulnerable people in urgent need who may be injured or in a state of heightened anxiety, shock or distress, in danger or who are deceased. They do this in circumstances where sometimes their own safety is also at significant risk. For emergency service personnel and military personnel on deployment, they often work irregular shift patterns, face long hours, fatigue, and the need to make often critical decisions under constant time pressure. And they do this some emergency service personnel do this almost every day for months or years on end. So what are the numbers of people that we're talking about here? So in Australia, there is currently 87,973 full-time military personnel and reservists in the Australian Defence Force. So that's about 60,000 people who are in the regular ADF and 28,000 who are active reservists. In addition, we have about 120,000 full-time emergency service workers. The majority of those are police, of about 80,000, followed by ambulance and fire and rescue. And in addition to that, we also have about 240 volunteers as well. So in South Australia, these numbers are actually really hard to find, by the way, but in South Australia, there's 6,300 full-time and active reservists in the Australian Defence Force, and that's about 4,000 people who are in the regular ADF and about 2,500 who are active reservists. Now, if anyone knows the number of emergency services personnel in South Australia, please let me know, because I couldn't find that figure, so I'm very sorry about that. And also the other important thing is don't forget those who have left service. So we can look at mental health conditions or physical health conditions in those who are currently in service. But what we do tend to find is that those people who are unwell do tend to leave. So if you really wanted to get a picture of what the full scope of difficulties are for those populations, you also need to look at those people who leave. So in the Defence Force, approximately 5,000 regular ADF members transition out of the Defence Force every year, and that's either completely discharging due to a medical discharge or retirement, or transition into the reserves. So this actually represents a significant number of people who are in the critical early stage of adjusting to civilian life and reintegrating into their community, which is by no means an easy task. So while international literature suggests that about 60 to 75% of transition military personnel report an easy adjustment to civilian life, it is likely others, particularly those who have developed a mental health condition while in service, or those who are medically discharged for a mental or physical health condition, are likely to struggle. So today I'm going to draw on some data from 3 separate studies that I've conducted over the last 10 years. And this is really a population-based research looking at military and emergency service personnel. The first study was conducted in 2010 and was part of the Military Health Outcomes Program of Research, and was called the ADF Mental Health Prevalence and Wellbeing Study. And this was a representative study of all current serving regular ADF members in 2010. So it was about 50,000 people, and we surveyed about 24,000 of them, and then did some interviews with a subpopulation of that group. What we found from that research is that there seemed to be this group of, we were expecting that there was a group of individuals who were leaving who were unwell. We did some initial analysis comparing those who had been on operational deployment versus those who hadn't, and were showing no difference actually in the mental health conditions between these two groups. So that indicates there's a healthier warrior effect. So people who are deploying are more likely to be healthier and then have lower prevalence of disorder. And therefore the people who aren't deploying are more likely to have mental health conditions. But it also implied that there's probably a whole group of people who are unwell who are leaving. So in 2015, we were funded by the Department of Defence and DVA to do the Transition and Wellbeing Research Program. And this is really to look at if that was the case. So we wanted to look at everyone who had left ADF service or transitioned out of ADF service between 2010 and 2015. And we wanted to look at the rates of disorder, mental health conditions in that particular population. So that included about 52,000 people who had left over that 5-year period. The response rates were a lot lower. I think we had about 14,000 people in the end who participated in that study. Obviously, when people leave, it's a lot more difficult to get them to engage in this kind of research. But it was a representative sample of all those people who had transitioned in that 4-year period. In addition to that, we followed up the group who we surveyed in 2010, who were regular serving members, and we followed up all those people again in 2015. So we've got a nice longitudinal cohort of people over a 5-year period. And there was about, I think it was about 8,000 people. Yeah, so 6,000 regular ADF members and 2,000 people who had transitioned by 2015. The third study I want to talk about as well was a study that we conducted in 2016. So this used very similar methodology to the mental health prevalence and wellbeing study and the transition study. And it looked at the entire population of Metropolitan Fire Service members from South Australia. So participants were drawn from 2 nominal roles, all currently serving full-time MFS personnel, which in 2016 there was 830, and all currently serving retained MFS personnel. So these people are usually in regional command positions and who are on call. All 3 of these studies actually used the same design. So it was a 2-phase design where a self-report questionnaire is administered in phase 1 to all respondents, and that has standard measures of psychological health, which is the K10, Kessler Psychological 10, looking at psychological distress, PCL, which looks at self-reported PTSD symptoms, and the audit, which looks at alcohol symptoms, and the PHQ 12, I think it is. It looks at depression. Once we send out that survey, we had 24,000 people, for instance, in 2010 complete it. We then selected out a subsample of individuals who we interviewed using the Composite International Diagnostic interview. So this is the interview that's designed by the World Health Organization. So it's the World Mental Health Initiative version, which is version 3. And it's the same version that's used in the National Mental Health and Wellbeing Survey that's done on Australian population. So we had some nice Australian comparison. In addition to that, we also had a robust 2-stage weighting process. So this adjusts for any selection biases and also attenuates the impact of low response rates for certain subgroups. So we know, for instance, that some groups are more likely to respond to surveys and interviews than others. So this weighting process allows us to take that into consideration, and therefore the prevalence estimates that came out are representative of the entire population. Same thing that's done in the National Mental Health and Wellbeing Survey. And then based on that, we can look at diagnostic rates of 12-month and lifetime disorder. And this is disorder based on ICD-10 criteria, which are representative of the entire population. And then in addition to that, we also have self-report mental health data, which looks at their mental health over the past 4 weeks. So I'll just sort of give just a quick definition of the term transition. I know so this term is thrown around a lot. This is really the terminology we use these days to refer to regular service leavers, including ex-serving ADF members and active and inactive standby reservists who've transitioned from the full-time regular ADF. So they don't say any more retired or discharged, it's transition, because people tend to transition into the reserves. So what are the key take-home messages in relation to all of this? So the first thing we found was that rates of affective and anxiety disorders are higher in current serving ADF members compared to the Australian community. So in this table, sorry, you can't see the top line because it's got is there any way to move that thing across the top off, maybe? Oh, it's okay if we can't move it, that's fine. So the column that's closest to the writing is the ADF. It's the full-time population of regular serving ADF members in 2010, and the other column is the Australian population. So what you can see here is that the ones with the little dots are the significantly more prevalent ones. So what you can see here is that PTSD is more prevalent in the ADF compared to the Australian population. So you're looking at about 8.3% of regular serving ADF members that meet diagnostic criteria for PTSD, and that's in the last 12 months prior to the assessment period, compared to 5.2% in the Australian population. Affective disorders were also more prevalent in the ADF compared to the Australian population, which is 9.5% compared to 5.9%. And this was mostly taken into consideration by depressive episodes. And interestingly, alcohol disorder was lower in the ADF compared to the Australian population. A lot of people are surprised by that. But, you know, really in service, there's a lot of conditions around alcohol. There's a lot of testing that happens in relation to alcohol. So that's not surprising at all that it's lower. Panic disorders were more common in the Australian community compared to the ADF. It won't go to the next slide. At least I'm sorting out all the technical difficulties here for everybody else that comes after me. How did you do that? Oh, okay, good. So this is looking at the Metropolitan Fire Service in combination with the Australian Defence Force and the Australian population. So the Metropolitan Fire Service, again, it's a national, it's a representative proportions based on the entire MFS. So they're in orange. The ADF is in blue and the Australian population is in yellow. And what you see is slightly lower rates in the MFS compared to the ADF, and really the rates of both affective disorder and anxiety disorder were pretty similar to the Australian population in the Metropolitan Fire Service compared to the national average. And alcohol disorder, like it was with the military, was significantly lower. So the second thing is there is a picture of increasing severity of both mental and physical symptoms from service to civilian life. And this is incredibly important for general practice, because when people are in the military, obviously most of their mental and physical health is covered by defence. So they go and see the medical officer in defence and they're treated within defence. But when people leave, they then sort of start to engage with the community sector. So this is where this is really important. So when we look at the prevalence of 12-month disorder in the transitioned ADF, which is in purple, versus the regular ADF in red compared to the national average, you see much higher rates, significantly higher rates actually, in those people who have transitioned out of regular service compared to those who remain in. So you're looking at sort of 46.4% with a 12-month, this is diagnosable disorder, by the way, using the city. So 46.4% of people who left the ADF between 2010 and 2015 met criteria for either a depressive, anxiety, or a substance use disorder. This is compared to 22% in the regular ADF and 20% in the Australian population. So much, much higher rates in those people who leave. This is mostly accounted for, well, actually it was accounted for by all disorders. So 37% anxiety disorder, 23.1% affective disorder, and 12.9% alcohol disorder. And what you do see here is a bit of a shift. So while alcohol disorder was lower when people were serving in the military, you can see once they leave, they actually increase in rate above and beyond the Australian community. So if we look at the individual disorder types, and we have in the percents closest to the writing are the regular ADF, so those people who are still serving, currently serving, and to the other side is those people who left. You again see much higher rates across most disorder types. In particular, 17.7% of those people who had transitioned out of the military met criteria for PTSD, compared to 8.3% of those who are still in. This is replicated for panic attack. So once again, you see panic attack is 17% versus 7.1%. There was also a higher rate of phobic disorders and people who had transitioned out of the military, and this was significantly greater, 11.9% for agoraphobia and 11% for social phobia, compared to around 2.5 to 3.8% of those people who were still serving. And this really sort of, you would see this anyway, I'm sure, in your general practice. This is really points to sort of the social withdrawal and stuff that happens in the community. And also then you see the higher rates of harmful alcohol use and also alcohol dependence. So quite marked increases there, 9.1% in those people who had transitioned versus 2.3% for alcohol dependence for those people who remain in service. Another interesting finding was the really quite elevated rates of bipolar affective disorder in this population, particularly in those people who are ex-serving. So 9.8% of those people who are transitioning out of the ADF met diagnostic criteria for bipolar affective disorder. So this is 4 times the civilian rates here in Australia. Now, we've thought a lot about this and we've done some extra research, and there's possibly 2 fundamentally opposite explanations for this. The first is that, well, A, it's a real issue. 2, the rates are high in combat exposed populations, but are often being missed by military medical providers. And this could be because they're unsure even to test for these kinds of things. They're not looking for it, and so they're missing it in diagnosis. In fact, there was a US study that found similarly higher rates of bipolar amongst those with PTSD. They looked at basically a whole group of combat soldiers who had PTSD, and the rates of bipolar disorder in that population were much higher. Or the diagnostic criteria as strictly interpreted are not appropriate for individuals with combat-related PTSD. And the reason for this is that it could be that those symptoms do appear normally as a consequence of their deployment. So things like persistently irritable for several days, that you had arguments, physical fights or shouted at people outside your family. You thought you could do things that others couldn't do. There was prolonged sleepiness, increased goal-directed behaviour, easily distracted and racing thoughts. So it might actually be that it's not bipolar disorder at all, but it's just picking up that these symptoms or experiences that people are having on deployment. And similar to the mental health findings, the transitioned ADF also reported more physical health issues as well compared to the regular ADF members. So that included more physical health symptoms, more service-related injuries, increased lifestyle risk factors, poorer self-perceived health, satisfaction and quality of life, and a greater risk of circulatory conditions, high blood pressure, musculoskeletal or connective tissue conditions, chronic low back pain, and nervous system conditional hearing loss. And interestingly, when we also looked at physical health conditions in the MFS, they had really high rates of musculoskeletal conditions as well. This is not my research, but it's some findings from the Answering the Call study, which was a national study funded through Beyond Blue, but led by University of Western Australia, looking at rates of self-reported mental health conditions in a national sample of emergency services personnel. And so this is the psychological distress and basically the proportion of people who are scoring in the low, moderate, high, and very high. So while diagnostic, it does give you a little bit of an idea about what's happening nationally across all of the emergency services. So the SES in the employees, the rates of psychological distress was much higher than the Australian population. The rest, there was no significant difference. And then when we looked at levels of probable PTSD, we see police are sitting much higher than the other emergency services in that respect. But once again, this is not diagnostic, but it's just based on self-report, then using cutoffs. The third thing I'd really like to draw everyone's attention to is the importance of subsyndromal mental health symptoms. Now, honestly, these should not be ignored. It's really important that we look at people who meet diagnostic criteria, and I know there's a lot of contention in the literature around whether you call it PTS or PTSD, and some people are in favour of losing the D, some people want to keep it. The truth of the matter is that if you have subsyndromal symptoms, there is a higher likelihood that you're going to go on to develop a full disorder later on anyway. So it's important to really consider those early symptoms. So in the mental health and wellbeing transition study, we showed that there was a substantial proportion of transitioned ADF members who reported subsyndromal symptoms. So these are people who score above the screening cutoff, but below the EPI cutoff, which is the epidemiological cutoff. So that's the cutoff that basically designates whether someone has a mental health condition or not. Like, for example, the PCL for PTSD, it's usually around 50. So this here looks at those people who scored either, we're looking at the K10 and the PCL, and we're looking at people who scored either below the screening cutoff in the K10 and the PCL. So they're the people who are on the top column there. So they're people who had no disorder in 2010. And then we looked at those people who scored in between the screening cutoff and the epi cutoff. Those people are the people with subsyndromal symptoms. And then we're looking at people who score above the epi cutoff, which are the people who have a disorder. So this is on the population, the longitudinal population of about 8,000 people. And what we did is we divided it up between, so we looked at the people in 2015, and then we divided it up into those people who had no disorder in 2010, and who had a subsyndromal disorder in 2010, and those people who had a probable disorder in 2010. So they're your three columns, okay? So what you see, because the top column's the longest, is that most people in 2010 did not have a disorder, right? There was a smaller proportion who had subsyndromal disorder in 2010, which is the middle column, and there is a small proportion of people who had full probable disorder in 2010. Now, if you break it down according to where those people sit in 2015, which is the colours sections, what you see is that 74% of those people who had no disorder in 2010 continued to have no disorder in 2015. Okay, so there's a consistency. So if you've got no disorder, you're more likely to have no disorder. There was a small proportion of those people who had no disorder in 2010 who went on to develop subsyndromal symptoms. That's the 16%. And there was even a smaller proportion who went on to develop a probable disorder. If you look at the next two columns, what you see is there is a higher proportion there of people who had subsyndromal symptoms in 2010 or a probable disorder in 2010 who either maintained those subsyndromal symptoms or went on to develop full disorder in 2015. So the reason why that's really important is what you can clearly see here is that when we're looking at people in 2015, regardless of whether they're still in service or whether they've transitioned, you can almost predict who's going to become unwell based on what their condition was 5 years prior. So this is why it's really important to start to think about subsyndromal symptoms. There is also some subgroups of military service members who are at a greater risk of poorer and physical mental health outcomes than others. So for instance, years since transition is a big one. What we tend to see in all of our data actually, and what we're also seeing in the suicide completion rates through the Australian Institute of Health and Welfare is that there seems to be this peak period at both the 1 year post-transition mark and also the 3 year post-transition mark. So 3 years in particular is related to higher symptoms of PTSD, affective disorders, but it's also a point where there's a higher risk of suicide ideation and also suicide attempts as well. Medical discharge is also a significant predictor of poor outcomes. So if someone's been medically discharged from service, then they're more likely to have both physical and mental health issues. So if you know that as a clinician, that's something that you should keep in mind. DVA client status, obviously also a predictor of poor outcomes, not because DVA is giving them the symptoms, but because they're engaging with the health system, which is why they're more likely to have conditions. Ex-serving personnel are more likely to have symptoms than those people who are still engaged in the reserves. So the more removed you are from service, the more likely you are to have symptoms. People who are lower rank in the army are more likely to have symptoms. And there's some sex differences, which are a little bit inconsistent across the individual disorder types, and also those people who leave service early. So if you're looking at those people who've only been in for about 4 to 7.9 years, roughly, they're your people at highest risk. And the final thing I really want to point out is the really, and this is quite an easy one to pick up actually, is problematic anger and cumulative trauma. So these are by far the strongest predictors of disorder emergence and progression. I won't go through this in too much detail, but bringing you back to those other figures I showed you earlier, again, you're looking at no disorder in green, subsyndromal disorder in yellow, and probable disorder in 2015. By far, across all of these models, the strongest predictor of either going from no disorder to subsyndromal or going from no disorder to probable, or maintaining disorder from subsyndromal to subsyndromal, or going from subsyndromal to probable, the most strongest predictor across all of those things was problematic anger and a number of lifetime traumas. So if you've had 4 or more lifetime traumas, you're much more likely to go on to progress and develop a disorder, or to maintain your disorder over time. So what are the conclusions here? So probably most importantly, service populations are overall, I'm talking about, and of course there's many people who engage in service who have absolutely no issues, and that's absolutely wonderful. But as a population, service populations are at an increased risk of mental health conditions due to the nature of their roles. There's particular subgroups of service personnel who are more at risk than others. These are people with high levels of cumulative deployment and lifetime trauma exposure. And to be honest, this is not a service-related thing. I'm sure you'll see this in practice all the time. People who have cumulative trauma exposure are more likely to have conditions. It's a wearing down over time. Early service leavers are at particular risk. Those who have left service due to a mental or physical health condition, that's not rocket science really. And those in the first 3 years following transition from service culture into civilian life. So I think as GPs or any practitioners, really, if you know those things, you know that you need to look out in those peak periods of risk. And the other thing is that there's a number of early indicators of poor mental health. So subsyndromal symptoms, so if people aren't sleeping, if they're starting to show a little bit of hypervigilance, if they're a bit emotionally dysregulated, all those things are triggers to show you that something might be going wrong here. It might not be, but it might be, and you need to pick those things up. Anger, suicidal ideation, and these are really easy things to ask about. So if we detect these things, in fact, if we acknowledge these things and even just ask and address it, then we can really start to prevent the progression of symptoms into something more long-term, which is very difficult to shift once you get into a long-term condition. So that's me. These reports, all the reports I've spoken about today are actually available online, and I'm happy to share this presentation and the links if you'd like to see them. Thank you. Yes. Duncan, hello.
Yeah, hi Miranda.
Go on.
Enjoyed your talk. Thank you very much. With regard to your bipolar figures, I thought I'd share with you some data that we've got from a recent audit of the Defence Electronic Health System record.
Oh, excellent.
So because of your findings, obviously, so I'm Duncan Wallace. I work at the ADF Centre for Mental Health. And so because of those very interesting findings, we were tasked to audit the Defence Electronic Health System records. So we looked at 140,000 electronic health system records using a panel of psychiatrists. We screened for every bipolar search term that we could find. And we looked at 2 financial years. And what we found was an extremely low prevalence. The 12-month treated prevalence for bipolar disorder was 0.03%, 0.03%. So that was extremely low, obviously much lower than your figure. And it was much lower than civilian figures, obviously. And it was much lower than the treated military population studies that we could find. There was nothing exactly comparable to our study, but it was significantly lower than any other treated military population study that we could find. So we're pretty confident in our methodology. So this then comes back to the question of why. So we're still figuring that out. It's healthy warrior. It's we think it's people not turning up, not presenting, particularly with bipolar 2. The bipolar 1 presentations usually end up in hospital, so they're pretty easy. Or it's our staff who are missing a bipolar 2 people who are, it's notoriously difficult to diagnose. They're often presenting with a couple of episodes of depression before they actually have their first hypomanic episode. So I just thought I'd share that with you. So we're hopefully we'll submit that for publication later on in the year. But the reports
we should combine up. You should combine up both results into one paper. Right. To show what happens when you do, like a sort of a population-based interview versus that. I think that's really interesting. And like you said, still the answers, I guess, as to why that might be the case. It's fascinating, isn't it? Absolutely. It
is. It was so much lower that we're sort of scratching our heads. So we're still thinking about it, trying to explain it.
I mean, it totally could be that the diagnostic interview is just not suited to this population. I mean, that's a really important factor as well, if that's the case.
Yeah, well, we were thinking that, but we're also mindful that it's a very well validated research tool. But yeah, at the end of the day, I think that might be a big part of the answer.
Yeah, and this is why it's so wonderful doing research with these kind of organisations, because things actually get practically done.
Exactly. So we thank you for your
great.
findings and your work, which led to our audit.
That's awesome. That's awesome. Thanks, Duncan.
Duncan, I was just going to say to that as well, that might be very much a presentation bias. So what people actually present to their MOs.
Sorry, just for the people online.
Sorry, guys, this is Jon Lane in the background. Duncan, I was just, really curious to see if this is about like a presentation bias, as in this is what they declare to their MOs, because they know it's going to have very, very significant consequences, versus when they're discussing things with researchers and just doing a generalized interview, and therefore probably far less inhibited about what they actually disclose.
Yeah, we considered that's one of the reasons too. But we're also concerned that perhaps our staff aren't as good as they should be. So an education program for Defence Health, we're looking at that to increase people's awareness, to routinely screen for bipolar disorder whenever we're seeing a patient with depression. So using something like the mood disorder questionnaire, but we're still figuring that out. So we're going to be able to translate that into some practical action. Thank you, John.
That's so great. That's made my day.
Yeah, I was going to say, it's an amazing piece of work.
Cheers, guys.
Any other questions? No? Thank you.
Hi, everyone. Well, we're just getting the slides set up. So I'm continuing on from Miranda's study, but I'm going to focus on the cohort of the families and how families are impacted. I'm the Associate Director at Military and Emergency Services Health Australia. I've been working with the organisation since its days at the Repat Hospital, and we're now based at the Jamie Larkham Centre, which is the PTSD Specialist Hospital in Adelaide for the military populations. And we run the research centre co-located with the hospital. So it's a fantastic opportunity to work closely with the clinicians at the hospital, as well as service providers externally in the community. And we work with universities across Australia. We're very much about collaboration and partnership. So we're just still waiting on the slides, but yeah, so I'm actually doing research I'm doing my PhD at the moment into a study on children of service families. And you'll see in my slides, there's a shortening of EFR, which is emergency first responder, again, including police, firefighters, ambulance, rescue, SES, CFS, and so on. And I'm studying intergenerational trauma for children, and also military populations and intergenerational trauma as well. So the study I'm doing is qualitative, and later in the slides I'll give a little bit more detail, but essentially 3 studies included. One has been qualitative interviews of children aged 8 to 18, and it's the first time that children have actually been interviewed, and I felt it was very important to include their voice in the data around what it's like to have a parent with PTSD and what their perceptions and experiences are. And also, I felt it was very important to interview both parent cohorts of the parent with PTSD as well as the co-parents. So I interviewed all 3 of those groups. They weren't necessarily from the same family. And then, and so I've done a thematic analysis on the data of those. So I'll talk a little bit about that in a moment. I also did a systematic review of all the literature internationally, of any studies done on emergency service family members. There is very little internationally. Most of it revolves around 9/11 actually, and focuses on the impact of the emergency service family members through those disasters. And again, even there's more on spouses, but even less on children. And then the third study, which I'll be commencing later this year, is a study on running a pilot program and that will be focused on children, but also with parenting workshops. That's not this, that's in the middle of the slide deck. And try and do it from memory. That's okay. So I will just try and do as much as I can from memory. First of all, I was just actually going to start in reference to a study which I think may be most relevant to GPs and other health professionals. And this is, I drew on a study which, just from my experience of working with these populations and some lived experience as well of being a carer, I feel that this particular study is something that I'd love to do in Australia as well. And it focused on how, it was from Canada, one of our friends and colleagues in Canada called Heidi Cram, Professor Heidi Cram. She came out to our conference in 2019, a big conference we held in Adelaide of experts in this area. And she did a study looking at how they could better support military, it was focused on military families, and how GPs, which are often a point of contact for them, could actually support these families better. So there are a number of findings from this study, and so I've just sort of translated those to the Australian context. But one of them, as a GP, in considering current serving military and emergency first responder families, is looking at issues when they present. So the sorts of things to consider is aspects like continuity of care. So for military and even emergency first responder families who are often posted, if you look at police, they're often posted in different locations, regional postings and so on, that for those families, they, particularly military families coming often interstate, they are moving around often with children, and so they are needing to find a new local GP and navigate and find the services relevant to their family's health needs. So they often present to emergency departments or walk-in clinics. And so there's a real lack of continuity of care for those families. Then you've got issues of managing gaps in care. So routine checkups and things that often you sent a letter from your GP clinic reminding you that you need to do a particular health check. Those things often get missed because you're no longer receiving that letter. So often even things like vaccinations are commonly missed. So these are the sorts of things to think about when you have a new patient coming to the clinic, and just sort of, I guess, informing generally in your practice. This is something to be aware of, to just check off these things. The other thing that can happen too is it can be quite hard to get records passed on. I know we have the, what is it called? The GP, what's it called? Anyway, the system through Medicare that we, we can store our records there, but not everybody's aware of that and how to use that. And sometimes specialist records and things don't get captured in those systems. Okay, we've got slides, yay. So this slide is just referring to the issue I was just talking about of continuity of care. Frequent relocations disrupts access to health services. Families will often use emergency departments and walk-in clinics, and it's often difficult to initiate or continue care with specialists, paediatricians and specialists. So this is particularly an issue where a family may have a child with a disability, for example, such as autism, needing continuity and familiarity of care. I know of at least 2 friends that I work with that have had this exact issue. One is an ex-Navy woman and her partner is still current serving. And as they've moved around, she's struggled with their child who's got autism to get that continuity of care. And every time they move, it's a huge process to find schools that will work with them, to find practitioners that will work with them and navigate those services. Another family, similar, both serving, and her child's got cerebral palsy and autism. And yeah, it's a really huge battle on top of an already stressful situation where you're managing relocations, you're managing finding all the services you need generally, employment, etc., for partners, as well as then supporting a child with a disability or health needs. And just remembering too, they've often got no family or friends in that new location to provide that sort of natural support network either. So it's really important to know about the serving member's current service. This can impact if they've been on recent or about to go on significant training periods and deployments. That can be very stressful on families. There's also that period of reintegration after deployments. So that's a significant stressful period for the family as they try and readjust back to their family setup. Research from the US tells us that children of military families are having increased rates of behavioural, academic and social challenges, and spouses have increased mental health concerns. This would be consistent with my own data from my recent study and also the systematic review that I did. So adolescents are starting to show more mental health issues. It's really interesting because I speak to so many people in this area and they say, oh, there's no data on children having mental health issues. The problem is all the research is showing it shows up as behavioural issues, and a big study done in the UK on serving populations showed high rates of ADHD in younger children, and that was of younger children who had a parent who deployed. So it's interesting that it is coming up as those issues. That PTSD is also a risk factor for families. And as Miranda spoke about, the subsyndromal, really important that we're picking up on those early indicators for families. So, you know, oh, he's a bit more cranky or he's moody or he's tired or he's not sleeping. Really important to sort of start to delve a bit further in how that's playing out for the family and any impacts for them as well. So in terms of the gaps in services, I spoke about that just before, special health needs, difficulties and delays in transferring records, and also being aware of the local services that you can refer to that are specialists for families. So for example, Open Arms offering counselling services for the families can be an important first step. So then we look to former serving families. So what can GPs and health providers consider when caring for former serving Australian emergency first responders or military families? So if they have had to relocate again, you're dealing, even though they've recently discharged, and they might, you know, be quite excited and seem quite enthusiastic about their new situation of their partner leaving service, they're still dealing with often settling in a new community, moving often to where their extended family is, and trying to set up their continuity of care. For example, a family I worked with, they'd bought their first house because they'd always lived in defence accommodation. So they were going through the process of buying their very first house at, I think it was like they were in their late 40s. And again, finding schooling and appropriate health services for a child with special needs. So longitudinal research shows us that the risks connected to transition in that first 3 years, as Miranda spoke about, there's a high level of often disconnectedness, and that's one of the risk factors. If someone is well integrated in their community, that supports their well-being. If they're not, that has the opposite effect, and suicide risks and mental health issues go up. So just again, being aware to ask those questions for someone that's presenting. The accumulative stress is an interesting condition, and it presents as an injury service, which can result in discharge at some point in service, but it can also appear after transition and much, much later in retirement. Working at the REPAT, there were so many times that we would have a Vietnam veteran who had been retired for some time presenting for the first time in acute care with their first time of getting a PTSD diagnosis. They'd held a career, they'd worked a very long time, they had this amazing grit to get through life, but they presented and having a sort of a complete breakdown for the first time in their 70s, for example. So it's just something to be aware of, that it can happen at those much, much later stages in life. And we're working with people like the chief of MFS, who they're very, very concerned about their retired members, because they want them to have a happy retirement and their families to have a happy retirement. But it is an issue that does sometimes come much, much later in life. So the earlier we can get access to those early subsyndromal symptoms, we can start to get some supports in place to hopefully flatten that trajectory. So it's really important to listen to the experience of families and ask how they are. Often when one of the things about PTSD, we talk about the splitting aspect of trauma, that you can be very task focused with PTSD, very high functioning with PTSD, and be very driven, often overworking. But then at the same time, often the wheels come off at home. That's where we relax, and that's where some of the depressive and withdrawal symptoms come up, or the quick to anger stuff comes up at home. So listen to the experience of family members. One of the things that we often talk about in trauma, and it's really good to have some tools at your fingertips. We use a lovely visual aids book with one of our therapists introduced at our centre, and it was from another fabulous Canadian. And it talks about the window of tolerance and the different arousal states that come from stress and trauma. And so it talks about trying to widen the window of tolerance and working on all the different strategies to keep that window of tolerance open, because you get the hyper arousal, which is all those hypervigilance type states. And then you get the hypo arousal, which is where you get the depressive, withdrawal, emotional numbing states. So little graphics like that can be really useful tools to have in the clinic to help talk about things like stress and trauma. So I'll just go through this a little bit quickly, because we spoke about some of these things. So the partner of a veteran of an emergency first responder or a veteran with PTSD can often be hypervigilant themselves. So it is quite common, and my studies show that again, for partners to have their own mental health issues and to have what we call secondary trauma or vicarious trauma. So the differences there between secondary trauma and vicarious trauma. Secondary trauma you get from exposure to the symptoms, the impacts of living with PTSD. So you're impacted by the constant vigilance of managing what's going on, the quick to anger, the emotional dysregulation, and all the aspects that come with that. The vicarious trauma is exposure to knowing what someone else's trauma is. So that can even be for children and partners if they were involved in the fires or let's say 9/11 or a major disaster, seeing on television pictures of what they may be exposed to and what the risks to them are, and worrying about your partner and what risks there may be for them. Paramedics and the recent health pandemic has been a big one for their family members, worrying about what they're exposed to. And that came up in a US study as well with the swine flu. So GPs, it's really, really important to ask, because the partners will often present talking about their children, talking about how they're navigating health services for their partner and all the things they've done, often checking in with the GP about, am I doing the right thing? Or I think I've done the right thing. I've followed up all these things. But it's really, really important to say, how are you? How are you doing? And are you getting support? Where are you getting support? Because, you know, when we talk about families, and we talk about suicide risk, when families break down, it does put the serving member at greater risk when they're on their own and isolated from their family and going through the stress of all those aspects. So the more we can support the family to function, which often means supporting the partner and children too, we can keep that unit together. For children, be aware that the secondary and vicarious trauma may present as behavioural and emotional issues, as I mentioned before. So ADHD comes up all the time from teachers and schools particularly, because these issues present at schools. And it will be the child that's looking out the window, unable to concentrate, unable to complete a task, having a sudden emotional meltdown. Being so, one of the key things I see in my study was girls are often called over emotional, so they burst into tears at the drop of a hat, and the boys would often have anger outbursts, okay, and be quite physical. So it's really important that children need avenues of support to be able to safely talk about these issues, and remember they're very protective of their parents. This was another theme that came out in my study. They might be suffering inside of what's going on at home, but they are so protective of their parent and parents. So it's really important that they feel, if you're offering them help, that it's not an attack on their parents. It's got to be talked about as supporting the family and helping the family. So as I mentioned before, some of the broader studies internationally, a lot of it is focused on the spouses, and it talks a lot about the spouses having to change their roles to become carers, issues with marital dissatisfactions and the impacts that has on the family, and then also post-deployments, issues with partners and children that show up at that point. I'll just skip through this. So one of the interesting things that we look at is mechanisms of intergenerational transmission. There is an argument for genetic transmission, and there's more research going into that. There have been proven changes of PTSD on the genes, and so it would make sense that that can be passed on genetically through conception to children. What that then means, you know, what does that mean for us? What does that tell us? Well, potentially it means a vulnerability, and we do see generations of mental health issues passed on, but the research is yet to come from that, and can it be reversed would be the other question. But in working with what we've got, we talked about vicarious traumatization, secondary traumatization, and primary traumatization, which is where there is domestic violence, or there is, other neglect or abuses and things going on. So their primary trauma can also occur, and you can have primary, secondary, and vicarious co-occurring. So the big thing with living with PTSD for parents, and look, this is a really sensitive issue. You know, I think as a parent in the room, and most parents would say, parent guilt is crushing. You know, we're all worried about how we've messed up our children at some point. And the parents, the serving parents with PTSD who brought their children in for interviews, you know, and sobbed in the interview because they were so worried about what their condition had done to their children, but B, also wanting help for their families, wanting some assistance on how to navigate through. And especially with the emergency service populations, they felt that there was no support for their families. At least with the military population, we've got this agency, this government agency called Open Arms. For emergency service populations, there is not an equivalent. Okay, so then having to navigate expensive community mental health services. So we really need to be very, very aware of how we can support those families and link them into programs, and we're hoping to develop more programs in that area. So the big thing around parental capacity is those dysregulated emotions, those arousal states. And then, of course, it comes to the maladaptive sort of coping mechanisms that come from that, and the avoidance behaviours. Substance abuse comes into those avoidance behaviours, and negative worldviews, and how those are then conveyed to the children. So I'll just skip through these, but we talk about direct and indirect transmission of trauma and how that manifests. So really interesting. I personally love this stuff, but it's really interesting to look at whether you're looking at refugees or whether you're looking at serving populations, of how trauma is passed on. And we talk about silence. There's under disclosure, that withdrawal, that numbing, where it's not talked about, and you hear about that in generations of serving populations. But there's so that under disclosure leads to a child struggling to understand or sometimes gain closure on what they think has happened for their parent, but they don't know. So sometimes they imagine worse than what's actually happened, and they're watching movies and pictures to try and understand what their parent has been through. Over disclosure is another one where someone is actually constantly talking about how bad the world is and basically giving a very negative worldview. Hard not to do sometimes, so over disclosure and that sense of urgent insecurity, threat to survival, real anxious attachment styles, lack of trust, those things then get instilled in the child as well. Identification. So children can then start to basically learn from the parent and adopt similar behaviours. And I certainly saw this in my study, where the children themselves become hypervigilant. And it can also result from a necessity of becoming over-parentified and taking on carer roles themselves. Reenactment is another one that they will be enlisted sometimes in reenacting trauma, but they can also then, it plays out in the playground and so on, that they take on that worldview. Moral injury. I'm not sure if many of you have heard about moral injury, or whether some of the other speakers today are going to refer to it, but moral injury is basically sort of a form of PTSD. The key symptoms you're looking for is guilt and shame, will be talked about a lot. And basically it's a transgression of values. So through your service, or it can be towards the end of service, that you're not treated well potentially as you're trying to exit service with an injury. That there is a moral injury. So you've witnessed something potentially, you've been part of something, you feel like you were the cause of something, or you had no control over something occurring. It comes with stigma too in the community around particular war events and particular, community things, that there is a community stigma that then gets tacked on as well. That can also be carried through to the children. So I mentioned about my studies. So the very next study is the co-design program pilot, which I'm very excited to get underway. It's something I've been wanting to do for years now. Just to give you a little bit of, I think we're running out of time. So just to give you a little bit of an update on some of the key findings of the qualitative study, which I will be publishing on soon. The systematic review will be published soon as well. But on this study, there's 4 key themes with many sub-themes underneath. But the first key one, the lack of emotional stability. This came through in all interviews as one of the key issues. So there was the don't yell, the emotional dysregulation, which eventuated in anger outbursts, or the complete withdrawal and emotional numbing. Please say something. This plays out in the home, where children are constantly being exposed then to emotional dysregulation, co-parent trying to manage that situation and the burden going on. The changed family dynamics and functioning, walking on eggshells is a really common way to depict that. So there's this overlay or cloud of tension in the house. A lot of spouses spoke about feeling absolutely anxious just to walk through the front door, because they can sense, or they know, that when they come home, there's going to be potentially something going down, and that constantly as a co-parent having one ear out to what's going on, what's going on over there, is that going to eventuate into a big conflict? So there's this tension in the house, and children are responding to that in different ways. Some of them, particularly single parent families, the child is often having to take on a carer role and be the one mitigating what's going on. So children are responding in different ways. Some are taking on the behaviour of withdrawing and going to their room and sort of avoiding what's going on, and they sometimes feel that that's the best way to cope. And other times they're actually getting involved in the conflict, and we talk about this spiral of conflict. They basically, it's this sort of firing off each other. The child's behaviour is getting worse and more escalated. The parent is responding to that, and there's this absolute spiral of conflict. And then everybody feels awful and goes away, and there's that damage there that is really, really tough. So another theme is the impacts on the child's well-being. So as I said, it's often showing up as behavioural or emotional issues, and doesn't play out often later, until later in adolescence, into a confirmed diagnosis of mental health issues. So the key thing there is let's get onto it early. And for help seeking, there was a real lack of help seeking options for the children. Often the family is so busy coping with a service member who's got a recent diagnosis or even a long-standing diagnosis, but dealing with the aspects of that the children's issues often get, and sometimes the children say, I don't want to bother my parents with what's going on for me. So I really sort of implore people to start to look at that, because otherwise we get those really long-term intergenerational impacts. Some of the organisations we work with, like Partners for Veterans, we've got women who are in that group, predominantly Vietnam veteran wives. And many of them say to me, my goodness, I'm not only caring for my husband, I'm also caring for my adult child who has significant mental health issues. And they say it's because of their childhood. And they say, but if they've got children, because they're not coping, I'm looking after their grandchildren as well. So you've got 3 generations right there of impact. The more we can start to work with children early, we start to cut that chain. So this was just a slide of the predominant emotions in that order that came up through my study directly from the children. And it is confronting stuff, but as a parent, this is the thing, the parents were saying to me, we want to change this, we want help with this. And I think, we have an obligation to confront these difficult issues. As I said, it often presents at school and in the social aspects of the community. So what can we do about it? As I said, I'm doing a trial program which will focus heavily on these issues. We have programs like John will talk about in a moment, which works with the service member around their emotional regulation and giving them the skills to manage, and also works with the partners. But developing programs that specifically focus on parenting and focus on the child is really, really key as well. So some of the skills and things that we talk about in working with trauma is those arousal states, de-escalation techniques, grounding techniques, really good thing to have in your kit bag if you've got someone who's escalated in whether it be a hospital setting or a clinical practice. Really, really important to have some of these grounding techniques at your fingertips and to be able to work with clients on them because people can't, when they're working with you and they are escalated, they're not going to be able to take information in. You've really got to get them to a calm state before they can actually take. And that's an important thing to remember too when you're working with clients, is they may not remember all this information you're giving them. So give it to them in written form. If you can follow up. But grounding techniques are great to de-escalate so they can retain. Self-compassion is huge. A lot of stigma still in this area. Self-compassion is key. And it's important to know that growth is possible for not only, we talk about post-traumatic growth, it's possible not only for the member, and I've seen it time and time again, but it's possible for the whole family to grow through this process if we can get some strategies for the family to work. And so, yeah, I keep that optimism and that hope there. Through the psychoeducation, through the understanding, through the support, the family can grow and function and, yeah, be stronger. So nice, that's from that visual aids book again. If anyone's got, I might save question time because I know we were just running a little bit behind and we'll probably get even further behind for John, unless anyone's got any burning questions right now. But if anyone has things that they'd like to follow up on, and I know there isn't a lot available in the family space, please feel free to get in contact. We've got some business cards here. So yeah, we can follow up afterwards. Thank you.
So if anyone does have any questions, feel free to ask, but we'll just take a 5-minute break. So for those online, we're just going to take a 5-minute break and we'll be back commencing in 5 minutes.
There we go. Can't you measure people? Go and sit down. Measure people, sit down. Yeah, we do. We are on a schedule here. So I asked for the break because I thought it was important just to actually stop, have a break and just reset our brains and things, because you've had a lot of information so far. And again, this is going to keep on going as well too. So for this next little bit, we've got myself and then Duncan talking. And just to point out as well that this stuff that I'm talking about here, myself and Duncan published a paper in Australasian Psychiatry last year on military culture for clinicians, which is very worthwhile for a read. And then Duncan has also published a paper, I was one of the co-authors as well, but on assessment in military and veterans as well too. So those are both very good resources to look up afterwards as well. So yeah, my name's John or Jonathan. I'm a psychiatrist in Hobart. I've had 30 odd years in the army, Afghanistan veteran as well. Do a lot of work with veterans and emergency services personnel in my day-to-day clinical practice. I've also been doing a PhD through the University of Adelaide, and Miranda is my primary supervisor, thankfully for me. But we ran a trial intervention of a program called STARE, Skills Training in Affective and Interpersonal Relationships, over 2018 through to 2019. And then last year, 2020, we introduced a program called GEARS, Group, Emotional and Relationship Skills. And a couple of the psychologists in the room and psychiatrists in the room here too are well aware of that. And we'll put a flyer up about that later on as well, just the website, so that you can refer people there. Because the focus for a lot of these things that we have talked about and we will talk about, actually emotional regulation is one of those key things that sort of falls by the wayside with people. And hopefully some of this will sort of, or why this happens, will come out in the presentation. So I'm obviously talking about an overview of the military and therefore the military mindset, and then, you know, what transposes to veterans as well too. So basics about the Defence Force. Can I just get a show of hands as to who treats active duty military at the moment? Yep, got a few. What about veterans? Who has lots of veterans? Yeah, cool. So the reason we're doing this is because culturally, the military and therefore by definition, the veteran population are different to mainstream society. And this is something that is a little bit novel in concept and construct, because when you think of cultures and subcultures, we tend to think about, you know, migrant groups, we tend to think about various other sort of ethnic groups, you know, various other sort of subcultures might include, you know, the bikie communities or any other sort of community you can think of. But when we think about cultures, cultures are defined by a number of different criteria. And so it's generally some sort of a history, some sort of shared experience, and those history and the experiences go on to make traditions. Yeah. And so the traditions then reinforce this is who we are as a separate sort of group of people from the rest of society. And then as a part of that, obviously you get language. And so language is different in that particular culture. And, you know, we could talk about the military and all the different acronyms and all the different slang sayings and all that sort of stuff. But again, you know, using a different language fits you into a different population. And that's because people say things that other people can't necessarily understand because they don't have that shared history or experience or whatever else as well. But then from there obviously goes, you know, connections with social groupings. And so again, if you look at your veteran population, most of the people that they feel comfortable with, and this is exactly the same for emergency services, will be from that same background. And so you can see here how those sorts of patterns of experiences and then ongoing behaviours continue to separate groups of people into different particular cultures. And that's why we're talking today about this. And so we're starting off by saying, here's a broad overview of what the military looks like, and then talk about what, you know, why is that important to you as a clinician? So 3 services, Army, Navy, Air Force. The US has the Coast Guard and Marines, and we don't. Yeah, so border force, obviously you could say is kind of an emergency services organisation because they have specific roles in different things. Yeah, and so that includes offshore roles as well too. But we have permanent and reserve. And in reserve forces, you have active and inactive. And oftentimes, as Miranda was saying before, a typical transition pathway for a non-involuntary discharge would be active military and then active reserve and or inactive reserve. And so inactive reserve just means you're on the list for 5 years or whatever it is, and then you can be called up in a time of conflict or something like that. But otherwise, you're just a normal person who doesn't even think about it, the fact that you're on that list. As a reservist, there's a regularly scheduled commitment for most people. So 1 night a week, 1 weekend a month and 2 weeks a year. That's what all the ads say, and that's the way it tends to work. Yeah, but you'll see people who are reservists who still very strongly identify with their military identity, even though they're a reservist and whatever else. And that's because of the force that this whole sort of construct carries with it. And that's primarily, as we'll get to in terms of recruit training and various other things that are done to shape people into adopting this particular identity as a part of this cultural group. So rank structures, why do we have a rank structure? Well, hierarchy is another one of those sort of key defining features of a culture or a subculture. And the reason why we have a rank structure is because it's about authority and power. Yep. And that's about effective effective direction of an organization in terms of what it does, how it does it, when it does it, and who does it. You need someone at the top to be able to say, you do this, you do this, you do this, you do this. And so obviously it rolls downhill from there. And so that organizational structure is fundamental to the way the military works and fundamental, again, to part of, that adoption of a specific identity. 2 different rank structures, officers and enlisted. Officers, tend to be more educated. The way we work in Australia is you do not have to serve as an enlisted soldier first. You can go straight into those officer ranks. But by definition, that means you have to be more or better educated, generally with some sort of a degree or so on, as opposed to enlisting in the army as a soldier. I can't remember whether year 12 is a mandatory achievement now, but it used to just be you could just go straight in. And so particularly in a lot of sort of lower socioeconomic areas, going into the military, parents signed their children over when they were 17, because it was a good way of having someone feed them, house them, and then keep them gainfully employed and to kick their ass when they got and went and did stupid things. Yeah. But the names and ranks and various things, differ between the services. But again, there's that key thing of you occupy this position in this machine. Yeah. So these are just some badges of rank and various other things. And you can see Navy as the senior service, Army, and then the Air Force, otherwise known as the Chair Force. But they, just another example of slang and various other sorts of things as well too, because again, like families operate, the services operate in the same way. And you can see, so the officer ranks are at the top and the enlisted ranks are down below as well. So what's different, how they're different, and why they're different? So the Navy, being the senior service, has existed for a lot longer in terms of our history of our defence forces within Australia. So the Navy exists to fight a ship, yeah? And so you get a bunch of people, you put them in a big metal box and you go and do this, this and this, yeah? And so, the Navy is structured around that as their primary purpose. Whereas us in the Army, we exist to go and fight the land battle, the land war. Yeah. So, having soldiers on a ship is only good when you can put those soldiers on shore so they can do their job. Otherwise, they're hanging around, aren't they? The Air Force, on the other hand, exists to operate aircraft, and that's to project power over longer ranges and to carry specific missions out and so on and so on. So if you think about the Air Force as a structure, it's focused around fighter pilots and fighting aircraft or logistics and transport aircraft. Yeah. And so everything then operates around this particular thing. And so when you think about it, it's kind of like a bunch of guys, like a rugby scrum, for example. You know, you've got a bunch of guys pushing one guy forward. That's the way that operates. Obviously, very, very different mentalities and mindsets in those sorts of things as well too, because typically it's only the army that has that, you know, face-to-face combat role. That obviously differs when you start talking about drones or Air Force Defence Guards or whatever else. But, you know, typically that's the face-to-face role that the army has that the other services don't. Training is fundamentally important because, again, when you think about training, it's not just about a skill set training. And when we talk about transition, which we will later on, you have to remember, again, when you're seeing your military and your veteran people, that there are life transitions that happen anyway. There's going to school, there is leaving school, there is going into the workforce, there is going into long-term relationships, potentially marriage, potentially children, and then retiring, and so on and so on. So we all have transition points within our lives. When we talk about transition into the military, though, you know, I talked before about that importance of culture, and that is fundamentally just, yeah, you can't overemphasize it enough, because to transition into the military, you have to transition into a separate culture, and then you have to transition into a particular identity as well. Yeah, and this is really, really important because it's what's done during basic training. I'm going to say, sorry, David. Yeah, you've obviously been in the army, or yeah, exactly right. So if you think about a recruit training sort of thing, you're brought down to the lowest common denominator. You are referred to by your rank, not your name, and so your specific identity is subsumed into a larger collective identity. And, you know, if anyone's seen something like Full Metal Jacket or whatever else, you can see everyone gets a haircut, everyone gets put in the same uniform, and blah, blah, blah. And again, to make your individual identity go. Yeah, you are part of a larger group or collective identity. And so basic training inculcates this, as well as the skill set as well too. And you can see what I mean here about the pressure to conform. And so when we think about failures in basic training, it's not generally a failure of ability, it's a failure of ability to transition into a culture and into that particular social grouping. Time and effort, much time and effort invested into this. And it's a well-oiled machine. And, you know, the question is, why do we do this? Well, to have an effective fighting force, you don't want someone who's going to go, why? No, I don't think so. That doesn't work, does it? Yep. And so when you think about an effective combat force, you have to have a group of people who act as a collective with a particular goal in mind, and they go and do things without questioning why or whatever else. A well-oiled machine. Think about that for a sec, a well-oiled machine. What's that got to do with an individual? Absolutely nothing, does it? And that's part of the problem. So roles and why they're important, because role is about function. I'm a gunner. Yep. So I work in artillery. Yep. And what do we do in artillery? We shoot big guns at people who are far away. Yep. But I have a particular role as a soldier in a gun line. Yep. I might be a loader. I might be an ammo bearer. I might be whatever else it is. And same for every individual role. Thing is that requires training and requires me to have a specific part. So I'm this little cog in this little bit of machinery, which is a big part of this big machinery. And so it tells me where I fit. And so that again goes down to structure, doesn't it? Because when we think about our lives and the way we live our lives, we all want routine and structure. That's how we get stability, because we can, well, generally have some ability to predict what's going to happen in the future, don't we? Yeah. And so when we talk about how this works in the military, and we'll go on to this, but your role identity then, you know, basically becomes the dominant thing in terms of who you are, how you see yourself, and so on. So it overrides that sense of personal identity. And then the social connections that you have reinforce the role identity too, because your social groupings are based around your occupational, groupings or activities. And so that's exactly the same for emergency services. Anyone that treats coppers, for example, ask them, how many friends do you have that aren't coppers? And they'll be like, yeah. And it's exactly the same with the military. So as you move into the military, you adopt this identity. And so people associated with your previous civilian life, you don't have the opportunity to see them because you move around. But you just don't have the same common interests. You don't have the same common shared experiences, and so on and so on and so on. And so those non-occupational relationships go, and you end up with just occupational relationships. And so that your role identity is reinforced by your social identity, and then it obviously subsumes and overtakes your personal identity. And then obviously rank, comes into that again too, because rank is about responsibility, but also authority. And if we looked at the way a typical infantry battalion would be organised, you can see what I mean about routine and how that then equates to structure, and about how you can see little cogs in a machine. So you have a section, roughly 9 or 10 guys, 3 sections in a platoon, 3 platoons in a company, plus or minus a support platoon, and then, 3 companies plus, add-ons. So again, a support company in a battalion. And then the battalion would be part of a larger grouping again there too. So a task group, as it might be called, you'd have your operational arm, then you'd have your support and logistics arm, and so on and so on and so on. And then with different specialist add-ons attached. So it might be engineers, it might be surveillance, it might be intelligence, it might be signals, and so on and so on and so on. But as you can see, it's again, a bit of machinery that has specific cogs, that have specific roles and specific duties and responsibilities. And those roles and responsibilities, again, reinforce individual or personal identity. But it comes down to occupational identity because of role. When we think about how you get someone to adopt a role as a part of their identity, when we think about identity, values are key to it. And values are so important because values, when you think about values, you need to think about attitudes, beliefs, and behaviours. And so when you value something, by definition, it's important to you, isn't it? And so when we transition into the military, these values are what are driven home into individuals through demonstrations of attitude, beliefs about, so attitudes towards something, beliefs about something, i.e. what's appropriate behaviour, what's not appropriate, and then attitudes are actualised or demonstrated through behaviours. So courage, for example, is one of the core defence values. And you can go, well, yeah, no shit, Sherlock. If you're going to send people off to go and do those things, yeah, courage is pretty important. But how does courage then come back to reflect on an individual? Well, it comes back to because I can stand up in the face of anxiety or fear and still carry out the mission. Yeah. And courage is also about, when you think about actualizing behaviors, courage is also about standing up about something that's wrong, for example. Yeah. And so on and so on and so on. So, respect is another one as well too. And you can say, defence's policies about harassment, sexual abuse, and various other sorts of things, they boil down to respect, don't they? And how do we demonstrate or actualize respect? Well, we don't do, we respect people. So we behave appropriately, politely, and all those sorts of things. And then we reinforce that through, specific rules about how you can behave. And, those sorts of things are obviously in the Defence Force Discipline Act and so on as well. Routine and structure are fundamental and very, very important because, again, if you have no routine and no structure, then you tend to be significantly worse off from a mental health perspective. And so unemployment, for example, is bad, not just because you don't have access to finances and things, but you don't have routine structure. Yeah. Why? What do you do when you get up in the morning if you don't have to go to work? When you think about the majority of your time being occupied by work-related tasks, you look forward to a weekend. Why? because now you can go and do what you want to do. Yeah. But again, you're time limited. So you develop your own routine and your own structure around what you do in your downtime. And again, when you think about transitioning from the workforce, regardless of what it is, one of those key transition tasks is to go, well, what am I going to do with my time now? Yeah. How do I actually develop some sort of routine and maintain that structure? But when you think about the military, you know, accommodation is provided, meals are provided, you're told what to do, when to do, how to do it, and so on from, you know, dark 100 through to whatever time. Yeah. And this obviously results in a high degree of institutionalization, doesn't it? And again, when I remove that routine and structure, I haven't removed the institutionalization, have I? And I certainly haven't, you know, removed that sort of identity that people have taken on. And in terms of reinforcing the identity, roles define function and therefore provide purpose. And when we start to think about military people, we are task-oriented. Why are we task-oriented? Well, we're task-oriented because that's my role. That's the whole sole purpose of me being this particular cog in this particular machine, isn't it? Yeah. So I have to be task-oriented. And completion of tasks is how you get validation. Oh, you know, you don't necessarily get a good job. You certainly get a kick in the ass if you didn't do a good job. But your sense of worth and your value as a person is based around completion of tasks. You'll see exactly the same thing in athletes, won't you? Yeah, anyone that's treated sort of high-level athletes, for example, this is a very similar sort of construct, and it's exactly the same with high-performing musicians as well too. If you're a musician, how do you get your self-worth? Well, you get your self-worth by performing, don't you? What musician is going to go, oh, yeah, I played really crap. Yeah, I'm so cool. No. Same with an athlete. Yeah, I came 5th. Go me. Yep, you have to have some way of validating why you didn't perform as well as you would have liked to have performed. Yeah, because when you don't perform, what happens? What happens when all of us don't perform? Well, that's when the self-criticism starts in, doesn't it? Yep. And then when our self-worth and our sense of value of ourselves depends on this performance within a particular task as a part of a mission, when you can't do that, then the self-criticism grows and grows and grows and grows. Why does the self-criticism grow? Well, again, as individuals, we do this anyway, don't we? You know, we do a task analysis afterwards and go, what did I do? What did I, I mean, it's that whole feedback thing, except with the feedback, you know, the shit sandwich feedback. Yep, good, bad, good. Yep. We just go the bad, 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 bad when we self-criticize generally. And then that obviously adds to, again, mental, you know, deterioration or deterioration in mental health. Because the individual in the military is secondary to the task. You know, why do we have people trained in particular ways? And, you know, you are a cog in a machine. And when that cog breaks, what do? Well, you get a new one, don't you? Yep, we don't necessarily care what happens to that cog because there's other cogs in the pipeline. Yep. But this is the problem though, because injuries, whether they're physical or mental, cause problems with performance, and problems with performance causes problems with self-worth. And this is it, because when your self-worth is invested in your role performance as a fundamental part of your identity, what happens when that breaks down? Some cultural quirks. Yeah, time and timings. I was late this morning. Yeah, I, you know, got in late last night, excuses. But at the end of the day, I got in late this morning. And so that's, well, because I was here at 2 minutes to instead of, you know, 15 minutes to or whatever else. But, you know, that's, you know, the way the army works is that you're told to be somewhere at a certain time. And so the sub or the unit commander says, be here. The sub-unit commander at, you know, a company level says, well, we're starting at 5 minutes before that. And then the sub-unit commander or the sub-unit commander says 5 minutes before the 5 minutes, before the 5 minutes, before the 5 minutes, before the 5 minutes. So you get somewhere half an hour early, and then you play this lovely game that we have in the military, and it's called hurry up and wait. Yep. Hurry up, hurry up, hurry up. Now we wait. Stoicism. So minimizing stress and distress, because again, being invested in performance, you know, it's part of that alpha male sort of thing, but it's also about performance, isn't it? Because again, you know, you have to keep up a front and everyone's got it tough. So what's the point in bitching? Yeah, suck it up, get on with it. Minimizing stress and distress is typically the way people will present, won't they? And so, you know, they'll say, you know, if you ask how you're going, they'll go, oh, yeah, I'm coping or whatever. But then behind that, there are so many other levels and layers. In terms of coping mechanisms, emotions and other things get in the way of doing the job. Yeah, because again, with emergency services, same with the military, you can't get distressed about doing something. So what do you do with those emotions? Well, you put them in a box and you focus on doing the job. Yeah. And that becomes like it's effective. It's a very adaptive way of dealing with stress, particularly in stressful situations. And it works to a degree for a period of time. But again, like Pandora's box, how much shit can you put in that box? And then when you open it, what comes out? And how do you shut the box? Well, you can't. And you can see when we go back to, you know, using this, you know, particular coping mechanism with emotions of repressing them, suppressing them, ignoring them, and so on, you can see where you get the hyper sort of reactivity and the hypo reactivity as well, because they're alternate sides of the same coin in terms of dealing with emotions and emotional regulation. And again, going back to being task-oriented, making something work is the primary goal. Completion of the task is the whole point. And so the individual then is obviously secondary to that. And so any cost or consequences of getting the task done, they're irrelevant at the time. Yep. And no one wants to hear about it afterwards. So shut up and stop whinging. Yep. And hence the minimization and the stoic attitude and all those sorts of things. But again, you can't let the team down. And so you can see that the focus for a lot of veterans is actually not about themselves. It's often more about other people. And there's that service as a value that is so fundamentally important, because people will be so externally focused necessarily rather than internally focused. And it's actually a point worth noting, because if you have veterans that are entirely internally focused, then without being pejorative, but oftentimes there's other motivations at play or other factors at play, such as personality disorders. And that is a real warning sign for people to sort of be aware of, because it will be then about, you know, claims for DVA or various other sorts of purposes as well too. And that goes directly to that external locus of control and the sense of entitlement. Because when you think about having an external locus of control, as in I'm told what to do, when to do, how to do, where to do, I'm therefore entitled to be looked after because I don't have that autonomy, do I? I've given up my sense of personal responsibility. Therefore, I'm entitled to some sort of recompense for that. I've sacrificed because I've served. There's my entitlement. And so you'll see a large sense of entitlement from veterans as well. And then going back to that sense of identity. Who am I and what am I if I'm not in that uniform? You transition into the military, all of your training and your service life is about reinforcing that identity. And what happens when you don't have that anymore? You know, when you go into the military, you're told civvies suck, yeah, effectively. And so what happens when you leave? Because you're not a civilian, but you're also not military anymore. So who are you and what are you? Yeah. And so that transition and the transition and discharge period is huge. And then thank you, Miranda, for covering that so well as well. But that piece of research is, I can't stress how important that is for us, because that information was not known until Miranda's study. Yeah. Obviously, you know, lots of ramifications for that, which are still being sorted out. But it, you know, it shows you the problems that we have, and that there are worse outcomes for people who are involuntarily discharged and unprepared. Because again, when you think about what I've talked about, that's another sort of, well, gee, that's a surprise, isn't it? You know, but significant burden of illnesses within the population and so on as well. So clinical pearls, Duncan will go into this a lot more in terms of assessment and things. But when you're doing a clinical history, it's about what your occupational history was. Yeah, and about what the highlights were and the lowlights and those sorts of things as well too. But asking about role, asking about particular experiences is a very, very good way of generating rapport, because you're demonstrating interest in what someone's life was. Yeah. And differentiating between the stressors and the traumas as well too is really important, because we tend to focus on the trauma, but the trauma is the icing on the cake. And it's the chronic stressors that make the cake. Yeah, and it's the reactions, coping mechanisms, all of those sorts of things. Those are the ingredients plus the experience over time that make the cake, and the trauma is just the icing on the cake. Because when you talk to someone, whether they're emergency services or military, and they've got, you know, an extended period of time in service, they've had a lot of shit. Yeah, and so when you ask, "Oh, what happened?" You'll go, "Oh, what happened when?" Yeah. Oh, which one? Which time are you talking about? You know? So it's effectively a developmental history and an occupational history as well too. So trauma isn't necessarily recognised as such, and what you see is undifferentiated symptoms, and they'll be primarily presenting as emotional regulation problems. And so take a transdiagnostic lens or focus when you're talking to people, because there will be anger. There will be a whole bunch of hypo or hyper reactive emotions. And then there'll be a whole bunch of functional deficits as well too. And so you might not necessarily get anxiety as a diagnosis, but you'll see hypervigilance. You'll see really poor sleep. You'll see hyperreactivity in terms of quick to anger, really low tolerance, you know, for frustration and irritability, and so on and so on and so on. Identifying the losses using a loss-based framework can be really good too. What can't you do now? Physically, mentally, occupationally, and so on and so on. That's a really good way of saying to someone, well, what impact has this had on you? Because you can't do what you used to be able to do. What are the coping mechanisms? You know, I have a drink or two every night. Yeah, just, you know, 1 or 2 bottles, something like that. Whiskey. Yeah. Yeah. And common. Yeah. So, and you can see what I mean about minimizing again too, because yeah, someone just say, yeah, a couple of cans or whatever else, and you find out they're drinking, you know, a dozen cans of, you know, Bundy, OP Bundy and Coke or something like that. So they're having 30 or 40 standard drinks a day. Yeah. And don't just settle for it's okay. And going back to that sort of loss of identity and function and things too, because social withdrawal, you've lost your primary social support networks because you've lost your role. Yep. When you've gone from the military or the emergency services, your primary support or social network comes from your occupational interactions and relationships. And so those have been lost. Then values and value systems as well too. I'm not a civvy, but what am I? And I can't handle talking to civvies because they just, yep. And so there's that clash of values and that value system as well too, which reinforces social withdrawal and isolation. So roles, therefore purpose, and therefore meaning in life as well too, obviously huge. And so in terms of recovery, rehabilitation, and those sorts of things, what we do is leveraging that individual's values, helping them understand the nature of their journey. So through narrative sort of style there as well too, and then focusing on what they do have and how they are different and therefore special in their own way so that they can move on. And that's obviously what you'd call post-traumatic growth. Yeah. When you think about this whole sort of process though, we're talking about that classic sort of developmental task of separation and individuation that we go through as, you know, teenagers, young adults, separate from the family of origin, develop our own sense of identity, the individuation, and then go on to be able to have a productive and meaningful life. It's got to happen again when you transition from service. You have to separate from the service, separate your identity from your service-based identity. And so, yeah, it's good. Concrete things you can do are obviously here on the list. But again, you can see, the key things here are asking about specific aspects of functioning in many ways. Sleep, coping mechanisms. Focus on those, because then you are tapping directly into the task-oriented mindset of that particular person. We're going to focus on this. Yep, understand the rest of your life is a shit fight. Let's just start here. Yep, let's try and how can we maximize your sleep? How can we get some activity going? How can we improve your social life, and your social connections so that you can have more supports and so on as well too. And this is, again, one of the primary reasons for the development of, the GEARS program, because, 12 weeks, 2 hours a week with a bunch of like-minded guys and girls who've all had those same common experiences, and then going through a manualized workbook in a structured process to look at all these emotional regulation and interpersonal relationship aspects of things, and focusing on and talking about identity and then individuation or separation as well too. So yeah, that's it for me for now, folks. When you think about things, think about the culturally different sort of things that you need to consider when you're talking about military, veterans and emergency services personnel. Think about what makes them different, why they're different, how they're different. And then that can obviously inform how you interact with them and what you focus on and your management goals as well too. So yeah, thank you very much. Denise, does anyone have any questions? Love that. That's awesome.
Thanks, Tom. Wandering around. I'll stand still for a time being. I'll let you know if I change my mind. Yep, lovely. Thanks. Okay, look, thanks very much, everyone. I'm going to change the pace a little bit. I'm not an academic, although I did do a PhD. And I'm certainly very much a clinician. And when I was speaking to Nick earlier about what sort of presentation I should do, so I'm just blaming you up front here, Nick. I'm going to do something very, very practical. I don't work with the military. I've probably treated a handful of vets in my life. I work very much with emergency services, and within that, it's mainly with firefighters. So I've been externally contracted to Metro Fire Service for 29 years. I'm also contracted across SAFECOM, which for the uninitiated is, now I've got to stop and think, South Australian Fire and Emergency Services Commission. So I work with the CFS, the SES, the Volunteer Marine Service. So I don't think I've ever seen one. I think there's only about 9 of them around. And I also, of course, do work with police. So my presentation today will be very much drawing on my experience with firefighters and police, but I do follow on very nicely from John's presentation, because his discussion about culture there is very much what I'm going to be focusing on now. So I'm not going to be able to give you a lot of statistics. What I'm going to give you is just my impressions. So I want to say right from the beginning that I'm not here to teach you how to suck eggs. I'm assuming you know how to diagnose. I'm assuming you know how to treat. What I am going to do is give you some thoughts about how people present and how best to work with them, how best to approach them. Now, none of this is going to be rocket science. And for many of you in the room, I would imagine that you'll go, yep, yeah, I do that. Yep. Well, anything more to add here? And that'll be fine because that's validation. And I also want to say that I think it's incredibly important not to go beyond the basics because, you know, we're all very diligent. We come off on Saturdays to training sessions such as this, and we're always looking for the latest, the newest technique. But sometimes we forget that it's actually the fundamentals that work. So I, for one, am always quite pleased when I go somewhere and can tick a few boxes and go, yeah, I do that. That's good. So I'm on the right track. For some others of you, some of these thoughts may be some new thoughts, and that's good too. And hopefully they will give you a bit of a mental framework on which you can draw. Now, this is very much building on what John was talking about in terms of the inculcation into that collective identity. Now, I don't think that we can even put it on the same level as to what happens in the Defence Forces, but there is certainly a similarity. And these are the sorts of things that people say, you know, we put ourselves in harm's way to protect you. And, you know, fireys will joke, well, you know, yeah, we're the ones that run into the burning buildings when everyone else is running out screaming. So I think we do need to think about this mythology, and this mythology is very much built up for them, but also by them. So it really does start right from the beginning and it perpetuates. So it is hard to get in to the police force. It's hard to get in to the fire service, and people know that. And it's not uncommon. I can't tell you the statistics for police, but I can tell you that it's not at all uncommon that people will apply for the fire service 3 or 4 times, and they just keep going until they get in. They're told very much that this is the best job in the world. And again, I think that that's what fireys are told, but that's certainly what police officers are told too. You are made to feel special. You are reminded of the fact that you have status and or authority, that people hold you in high regard. Now, I did a bit of a Google, having really nothing to do. I had a bit of a Google as to where do police officers, where do firefighters sit on the annual most respected lists. Interestingly, it depends which list you read. The bottom line, though, is that both of them always come up really, really highly. And that's something that they're all reminded of. You wear the uniform with pride. You're a fiery 24/7. You know, one of my, I'll say mates in the fire service, because after 29 years, I guess I have developed quite a few friends within that service, will talk about the fact that, you know, people in their street will know that they're fireys. And will pop down and ask for, you know, assistance, won't feel any qualms about doing that 24/7. You know, and when you get the job, again, I can't tell you this about police officers, but there's a wonderful service, this wonderful ceremony when firefighters graduate. You know, the minister comes in, politicians come in, you know, maybe or maybe not, that's a great thing to have, but certainly it bestows status. And people come and celebrate the fact that you've graduated. And I, over the years, taken many pictures of the end part where after they parade and they're called to attention, then they're told to at ease. And then they throw their caps in the air. So, you know, they're all like they're performing on Top Gun or Officer and Gentleman. So there's a real celebration about it. And that uniform thing, I've experienced it myself. I have actually deployed with some firefighters, both within the state, and I went to Kinglake those years back. And I just had a level 1 shirt on. What that means is, you know, basic protection, and, you know, had emblazoned all over it the Metropolitan Fire Service. And I was absolutely struck. The minute I got off the plane, people in the airport were touching me. They were they were touching at the sleeve and saying, thank you for coming. And, you know, we drove up into the hills, and we stopped halfway just to grab some water. And the people I was with, who were the real firefighters, were in the shop. I'm just sort of standing outside. And again, somebody came and clutched at me and said, thank you so much. And I started to say, oh, look, you know, I'm not really. And then I realized that that was just not what they wanted to hear. So I sort of very graciously said, that, my pleasure sort of stuff. But the power of the uniform is there. And as John talked about, you enter a club which sets you apart from others for so many reasons. Now, everybody loves a hero, but coming back to the purpose of this presentation today, where can this lead us as practitioners to go wrong? And I think we too can become beguiled. We can become too interested in their occupation, too interested in their story, and forget to ask about, you know, what's their part in it in terms of how they're coping. We can clearly misread their presentation due to their bravado, and there's so many reasons, as you've already worked out, as to why first responders will present that way. And I think it's also hard to get the balance right. These are people that are used to being in control, so they want to control their treatment too. Right, I'm here because I'm just having a few problems, just do this, help me with this, and then I'll be fine. So I think we do need to get that balance right between allowing them to stay in control and to guide their treatment, and also for us to exercise just a little bit of influence as to, you know, where else we should be going. And that's hard to get it right. I think we too easily jump to PTSD rather than exploring a range of diagnoses. You know, PTSD is certainly the sort of the sexy diagnosis, if you like. And John, I think it was John, might have been, I don't know, so many good presentations this morning have talked about the fact that many people don't want to have the disorder part in that. And certainly I know that police officers and certainly firefighters like to think of themselves as industrial athletes. So if they have to be injured, and God forbid if it has to be a psychiatric injury, then, well, you know, I'll begrudgingly accept PTS, or if you have to put a fourth letter in, make it PTSI, but I'm not sure about this PTSD business. So, you know, if they're feeling that there is a need for a diagnosis, and of course we all operate in systems, you know, I very much take John's point about the importance of it being transdiagnostic. That's of course what it needs to be, but that doesn't fit so well when you've got a workers' comp claim and they're wanting a diagnosis, and they want it very specifically. So I think we do readily jump to PTSD rather than to think about these either the comorbidities or the alternative diagnosis. And I think obviously there's that connection between the physical and the psychological, and they will frequently present for physical problems rather than psychological, because it's far more acceptable. And we can be put off asking the hard questions. Now, I don't just mean that hard question about suicide. Of course, you need to ask that, but we need to ask about substance abuse. We need to ask about, and include in that, steroids. We need to ask about gambling, and we need to ask about domestic violence, because heroes can be flawed as well. And sometimes when we think about people and put them on a pedestal, we forget to ask some of those sorts of questions. But heroes are flawed, especially when they're flesh and blood and not just on a screen. Now, I'm just going to give you a few general comments first about how to think about emergency first responders. So many are storytellers. And why wouldn't they be? You know, they spend a lot of time together. You know, so police officers spend a lot of time in a patrol car with other police officers, with their partner. Fireys hunt in packs. You know, they have a whole big truck packed full with people. So they have a lot of time spent with other people. So they are storytellers. And I did smile when John mentioned hurry up and wait. Because certainly I learned that firsthand when you go on deployment. It is hurry, hurry, hurry. And then you get there and go, well, just wait over there and we'll let you know. So hurry up and wait is something that is very common. And of course, when people tell stories comes humour. And a lot of that is black humour. So you do need to listen. So, you know, they've got time on their hands quite often. And so sometimes these stories can be very long. So you will really lose rapport with them if you are trying to hurry them along. Now, again, the realities of time. As a psychologist, I have an hour. But even that, let me tell you, is just not long enough. You're thinking, jeepers, just to hurry up a little bit. And as for GPs, well, you haven't got a hope. You know, they could be settling in. They'd be quite happy to settle in for half a day. When I go out to stations, you know, just to check on general welfare, we often do a situation where we might have a bit of a chat around the mess table, and then they'll be asked just to file in and just have a brief word with me. And that way, if anybody actually needs to see me, they're not standing out. Because if you ask who wants to see the psychologist, you're not going to get run over in the rush. And, you know, the reason for me to sort of digress on that is because everybody's sort of going, oh, yeah, all right, yeah, if I have to. But then I'm crowbarring them out of the room because they're storytellers. So it might mean that you have to think very carefully about delaying your diagnosis and delaying some of the really specific stuff that the frameworks in which we work are requiring of you, because it needs to take time. Think about the meaning, the subtext, what they're saying, what they're not saying, and follow up on hints and throwaway lines. People are practical and doers. You know, they're good at their job. They expect you to be good at yours, but you don't have to impress them. You don't have to sound like you know everything and use lots of terms and lots of jargon. In fact, if you do, you're going to lose them. And I think that that is part of that culture, that, you know, people are very happy to take you down a peg or two if you get a bit too big for your boots. But don't in any way mistake the practicalities and the doing nature of people for them being unsophisticated. Certainly, that may perhaps have been the case in older generations of police officers and fireys. But these days, it's not uncommon at all for people to enter those sorts of professions with 1 degree, multiple degrees, to come in with senior leadership experience. You know, I recently was at a station chatting to somebody that had previously worked as a physio and had also been doing some really fascinating research about age and the way people experience emotions. So these people know what they're talking about. So make sure you, though, explain in practical terms, and then if you can, give them something to do as they leave your room. Now, grounding techniques, as has been mentioned before, that's a really good one. Give people some grounding techniques, give them a website, ask them to ask their partner something, do something practical. Provide a framework for understanding. Again, they're accustomed to being in control. If you're going to give someone a gun, if you're going to ask people to go and chase madly around the state after offenders, if you're going to ask them to run into a burning building, you really do want somebody that has good levels of control, good levels of emotional control. You want people that are accustomed to making sense out of chaos. So, you know, we've got to expect that what we're dealing with are people that believe that they're in control, like to be in control, and they want to be encouraged to be able to regain a sense of control if they do come for your assistance. And part of that is giving them that roadmap. How did you get here? Where are you now? This is where you're going, and this is how we think we're going to get there. So help them regain that control. Now, this is something that I'm sure most people in this room would understand only too well. Most don't see it coming, or they choose not to. Now, the sorts of things you'll hear is, it hit me like a sledgehammer. It came out of nowhere. Happened so slowly, I never really noticed what was happening to me. Now, I think that what I would suggest is that with treatment over time, I'm listening out for people then to say things like, you know what, when I'm looking back now, I do think I can see it. And I think that that's a real shift in your phase of treatment. So I'm suggesting to you to start with, people will present a bit like, stunned mullet. What? Where did that come from? And then as you start to treat them, they will start to understand and look back and see things. They also might give confusing messages. And this goes back to that bravado. They will report symptoms of distress, but before you can even get anything out of your mouth, will say, but I'm fine, don't worry about it. So they'll say things such as, I'm capable of putting it away and just leaving it there. So, yeah, don't worry. I probably shouldn't have used your time. You don't need to see me anymore. This is just part of the job. It's normal, something to deal with, no big deal. You'll also find that they will seek help late, as they're so accustomed to becoming or to being resilient that they just keep moving that line in the sand. Well, I might seek help when this happens. I might seek help when that happens, but that happens and they'll go, yeah, I haven't given enough of a go yet. And so the line shifts. And I think that that's a really important thing. And I will frequently ask people when they tell me that they're doing okay, what would you notice if you weren't? Would anybody else in your life notice if you weren't? Who are they? And would they tell you? And then what would you do? And the what would you do question is a really interesting one, because frequently they'll tell me, probably nothing. Well, is that really the most sensible option? Maybe not. Well, then how would that change? So that's another line of inquiry. And they quite frequently disappear off the radar very, very quickly at any sign of improvement, because it just reinforces, yep, I just needed to work a bit harder or give it a little bit more time. And of course, I'm fine. And interestingly, I, over the years, can look back in notes and see presentations over, maybe 5-10 years. And I think it's really important that this is to think about building relationships. Now, clearly from listening today with people in active defence roles, you don't get that luxury. But hopefully with most police and fire, you do. And if they can build a relationship with you and trust you, you might only get this sort of level of treatment this time and maybe a little bit more this next time. But over time, if the chips really get down, they'll come to you. Now, let's start to be a bit more specific. I don't need to read all these things out. You've seen some of these things before. I will just make a note about prior exposure, employment and other. Within sort of an emergency first responder population, especially within country regions, you'll find that on the weekends, they just swap colour uniforms and get on a different coloured truck. So, they might be riding on the CFS on Saturday and then they change into a yellow uniform and work for the SES on the Sunday. And in some country towns in this state, there's actually career fire stations, so MFS retained stations, and they might be in that as well. You'll find then that similarly that the local country copper will end up volunteering for fire. So I think it also goes back to what John was talking about in terms of, well, who are your friends? And that's very much, instead of joining the tennis group, they join the CFS. And I don't say that to be silly. There's actually quite a distinct choice. You're either somebody that's off playing tennis or you're off with the emergency services. And I think the question when they present to you is, why now? What's happened right now? I think that's a really, really important question to ask, and it will give you a lot of information. And after you fish, then it's time to dig. So don't give up. Don't be distracted by red herrings. Don't interrogate, because if you do that, you're just going to lose them. But be clear as to why you're asking specific things. Be clear as to why you're not giving up on a particular point so that they don't think that you're the slow learner. And remember that avoidance is the hallmark, really, of trauma exposure. So, of course, people are going to avoid. So it's really important to think through, okay, well, you know, I might have taken reams of notes here, but what's not in these notes? What hasn't been talked about? What hasn't been done? And thereby you might get some gems. I think that both police and fire are really good at focusing on their body more so than their feelings. So, you know, I think it's usually quite a safe space to start in terms of, you noticed any changes in your body? Have, you know, you've been getting more, you're getting, you know, your kids picked up your kids' colds a bit more easily or whatever. Any other health problems? And of course, those health problems are just so important when we're thinking about long-term psychological problems. And the wonderful study that Miranda was talking about with the MFS showed very, very clearly that strong correlation between mental health diagnosis and physical health complaints. That was absolutely a clear finding. So, you know, start easy, look at the body. And then what's in your head? Now, this really is talking about shame, embarrassment, confusion, and self-doubt. That's what we're talking about. I thought I was stronger than this. This is strange. You know, I'm the one that helps others. I've lost my confidence. I've always seen myself as a very resilient person. What's happened? This isn't me. They look in the mirror. This isn't me. Who is this person? I never thought this would happen to me. Now, you know, when you've been so accustomed to being in control and suddenly you've lost your roadmap, then you're in strife. And I really like thinking about where was the real cliff edge, which is essentially looking back, what really was the straw that broke the camel's back here? When should you have sought help? And almost without exception, I find that when people start to have a bit more treatment, start to unpack, they're actually able to step away from it and go, well, you know what? I told you that that was the thing that really was the real issue. But I now look back and, you know, I fell over the cliff way before that. And if I was going to name an incident, and of course, usually there's so many incidents that they often can't, but it was way before I thought that the cliff edge was there. So I think that that's a good way of doing it. And people seem to relate to that sort of concept. Now, picking up on Karen's wonderful work, what's happening at home? You know, again, I'm always amazed when people sit in front of me and say, no, look, I protect my partner. I'm sure he or she really has not a clue that I'm struggling this much. Maybe they think I'm occasionally in a bit of a bad mood, but no, I'm pretty good at hiding it. And I'm just sitting there going, oh, well, you know, maybe we could bring your partner in. And then the partner's going, oh my God, let me tell you this. So, you know, they're kidding themselves quite often. And they will disappear physically. So they'll keep themselves really busy away from the home, and they'll disappear emotionally. And again, as we've heard before, one person at home and another outside. And again, going back to that study on the MFS, another really clear finding was low to moderate distress impacted adversely across all domains. But where did it show most? In the home. Where did it least disrupt? At work. You know, so really important to recognise that. And try very hard to bring in the partner if you can. I just loved all of the earlier comments about the subsyndromal stuff. I bang on all the time about this to whoever will listen. I think that the quality of life indicators are the things that we really need to look at. Because we do know about them pointing towards eventual problems. And I think also because, as John talked about, symptoms can be so diffuse, I'm not sure that we can ever be really clear, are we in some sort of prodromal stage, or are we just seeing a different presentation with a full-blown condition already? So these are really critical things. And the chicken or the egg, I'd love for you to think and ask about the role of organisational stress factors. I mean, these people work in organisations just like the rest of us. So, you know, we all know what the adverse negative effects of organisational stress factors are on the rest of us and the general population. So, of course, they're going to be in organisations of first responders. But I think we need to be checking, are people stressing out over these organisational stresses far more than is warranted, because it's really about the fact that they're just not coping? Or if they are seen as the problem child, are they really the problem child because they just popped out of the womb being personality disordered, or is it because of them being unwell? And then we need to think about, well, who's looking after them, or who are they clashing with, and what's their mental health like? So chicken or the egg is a really important thing to think about. And again, this is a really nice way of presenting it to them. Okay, I've been thinking about what you've been telling me, and I guess I'm thinking about that old chicken or the egg stuff. And that just seems to be a bit of a way of, you know, a slightly less formal way of introducing this thing. Again, coping strategies. Now, I don't need to go on about this in very many ways, but there are a couple of things that I do want to say. What do you do to cope, and how does it help, or does it help? And have a look. Like, we all can see the helpful stuff, we can all see the unhelpful stuff, but I think we often overlook things which are what I would call a too much of a good thing. So, for example, if the coping strategy is going out for a run, going out for surf, you know, entering marathons, etc., on the surface of it, you could say, oh, really good, healthy exercise. But really ask, what is the person avoiding by doing these sorts of things? And frequently the answer is, oh, no, I've got to be tired out, I've got to be busy, because otherwise if I'm just sitting down, then everything starts flowing back into my head. So too much of a good thing. And I'm sure that everybody here would know of Professor Sandy McFarlane, and Sandy was one of my supervisors for my PhD. And one of the things that sticks in my mind that he's always suggested that I should ask is, re-drinking, ask if they're drinking less. And that was actually a really helpful little tip for me, because if people are drinking less, why are they drinking less? Is it because they're realizing that they've got a problem and they're desperately trying to regain some sort of control? So I pass that tip on courtesy of Sandy. Now, being in the workplace and gives them the illusion of control. And I think that being busy at work is another thing that we all need to look at. We know that best practice tells us that we should treat people in the workplace if we can, and as long as further exposure is not going to be a problem. But it can have that sort of double-edged sword to it, because it's the thing that basically I feel like I'm doing what I should be doing. I just need to get on with it. I know what I'm doing. I'm okay most of the time. This is part of my life. I'm used to feeling this way. So really what we've got here is the sort of person that is comfortable in the workplace, at least they know what to do. You know, when they get a call to go out somewhere, they know how to function. They're with their colleagues, they feel understood. But is it just perpetuating the problem? So I think it is really important. And look, I should have said this at the beginning. These the things that look like quotes, what I've done is I have brought various statements together rather than pull out actual people's quotes. So ethically, I'll just make that claim. Now, when is enough enough, and then what then? Now, we could spend all day on this, so I'm just going to just float through fairly quickly and make a few little comments. I think it's really important that when somebody starts talking about getting formal treatment, and especially lodging a workers' comp claim, again, that why now question is really important. When you're talking police officers or firefighters, you know, you're actually pulling them, you probably pushing them towards making a claim. You know, they don't want to do that sort of stuff. It is something that is not on their radar. So if they're starting to say, well, I'm thinking about a claim, then I think it's really important that you ask why now, what's been going on, and to check out what are they hoping for, but more importantly, what are they fearing? So I've just thrown in a few little thoughts here. I think for the majority, it's proof that they've failed. They've let themselves and their family and their colleagues down. You know, basically, I've tossed in the towel. I can just see I'm going to need more help, and yeah, just do what you need to do, sort of stuff. So they're at a very fragile phase of their condition, and it's then public. And I think that that's a really important thing, that sense of public shame or public failure. And of course, we could, again, talk for a very long time about the fact that claim determination is very much seen as questioning integrity and can be absolutely brutal. Now, I do want to just put in this thought about I'm scared of what I might do. I hear that all throughout the treatment phase, not just within when someone wants to lodge a claim, but it seems to heighten at that point. And I'd be interested later if there's time for discussion on people's reflections on this, but I see a bit of a difference between police and fire. With police, I'm just finding more around that fear of rage and blowing up. So it's fear of reaching my limit and snapping. Now, then with police included, with everybody, it's fear of breaking down. So I'm scared I'm going to reach my limit and cry, or be, you know, emotional in front of other people, or looking stupid. I fear I'm going to reach my limit and not perform. And that goes back to the stuff that John talks about. That task thing is and performance is just so absolutely critical. And they all worry about, will I ever come back from this in the eyes of others? You know, are they going to see me as a lame duck, a risk? You know, when the chips are down, will they be going, oh, I don't want him or her with me? You know, it can't be counted on. And it's fascinating how many people have various names for it. So they can name individuals from the past. They have little sayings about it. So, and they're all very derogatory, and they do not want to be seen in that light. And then I think we just should go back to the idea of focusing treatment on what matters to you rather than what's the matter with you. You know, that's an old chestnut, but I think it's still very relevant here. And finally, if it is time to go, and by that I mean either leave the service full stop or leave operations, that's when camaraderie becomes such a double-edged sword. You know, essentially I hear people frequently telling me, I'm tired of the death and destruction. I've had enough of this sort of stuff, but I don't want to leave my mates. They're the only ones that really understand me. We talk the same language. Where would I get that again? Oh, yeah, I've rethought that. So no, I don't think I'll look at that. So, you know, they just hang on because they're so inculcated into that. So it is a double-edged sword. They go from being someone to just another someone. And that goes back to that whole thing about the mythology. They have to reinvest in their partner and their family, if there is any at that stage. And again, John made mention of this, you know, it's important that you help people be very wary and mindful of cynical or bleak, dangerous world type outlooks. There's no doubt that you don't want them to go to the other way, but somewhere in the middle would be really nice. And of course, adjusting to less rules and structure. And I'm going to add change of pace. You know, there's an adrenaline rush. I'm sure there's an adrenaline rush in the Defence Forces. There's an adrenaline rush in police. There's an adrenaline rush in fire. And you don't get that elsewhere. So they go from the bells dropping is what's the term for fire, bells dropping, and they're on. So suddenly there's an emergency. So lights and sirens, everything's happening, immediate reinforcement. You know, if you're doing something with an offender in an offender environment, there's immediate reinforcement, leaving aside the hurry up and wait type scenarios. If you go to a burning building, or for firefighters, if you go to a motor vehicle where people are trapped, you know, right, very, very quickly whether you are actually doing anything good or not. That change of pace, you know, it's really important. That is something that needs to be worked on for people if they're going to leave an operational role or leave the service full stop. So therefore, again, I'm just saying what everybody else here has said. The key issues to address are, who am I? Where do I fit, and what matters to me? And re-engineering this both to the now and to the future. So there's a few thoughts. Thank you very much.
Did anyone have any questions for Denise? No? Okay. Next up, we have Duncan and Nick presenting. Duncan is online from New South Wales. Unfortunately, with the COVID situation, Duncan has not been able to come in person. Duncan, can you hear us?
Yes, ready to go.
Wonderful. You should have control over the presentation there, Duncan, if you...
Not yet.
Not yet. Second.
All I can see is Denise's slides. Here we go. We're up.
Sorry. Exit, escape. There we go. Okay, Duncan, you should have control now.
Good. Thanks very much.
Did you just want to test going back and forward before Holly and I step away?
Yes, I'm trying.
Yes.
I can't. I am having trouble reversing though. It's not giving me the right click option.
The forward click. Oh, okay. I can go backwards there. Did you want to? You can click forward.
I can click forward. Stand by if required for reverse. Put reverse gear. Thanks, everyone. So my name's Duncan Wallace. You can see where I work. My major job is a psychiatrist at the ADF Centre for Mental Health. So I'm going to be talking with you today about improving your assessment, your mental health assessment of military personnel and veterans. So I begin with an acknowledgement of country. I pay my respects to the traditional owners of the land on which you are at and where I am in Currajong in New South Wales. Pay my respects to their elders, past, present and emerging, and also give my thanks to Indigenous men and women who have served in the Australian Defence Force. So this is what I'm going to be covering today. So this is a talk for clinicians to try to improve their ability to assess military personnel and veterans. So John's already spoken about the importance of culture. But as you begin to assess a patient, this is where you're going to run into head-on military culture. If you have served in the military yourself, then you know about it. But if you don't, then this is where you need to learn about it. And I think military culture can put people off treating military patients and veterans. But whilst military service is desirable, it's not necessary to learn how to treat military personnel. So you can learn how to learn about military culture through talking to your patients, through asking them what those acronyms mean and asking what those slang words mean and asking about rank structures, etc. You'll find out about military culture. And so individual members of the military, they learn their culture at recruit school, when they learn how to march and salute, etc. And then in their initial employment training, when they become a cook or an infantry soldier or a pilot or whatever, and then through daily service life. But also people learn military culture through many of the cultural reform programs that have been developed in response to a lot of problems with abuse. Now, there's a long list of reports about abuse that occurs in the military, and unfortunately, bad things happening in the military is part of the military culture. And we have to recognise that it does occur, but Defence tries very hard to address those bad things when it happens. And there's been changes, there's been programs to address these cultural problems, been going on for a number of years. They're constantly evolving, and there's a lot of emphasis from senior commanders to ensure that culture changes. So these problems are recognised, and there's a lot of emphasis to try to change the bad parts of military culture. So talking to your patients about what they do, their day-to-day work, are they a shift worker? How much time do they actually spend away from home? And starting with a full history of their service life. Obviously, as part of a comprehensive mental state examination, you need to take their personal history as well. But for purposes today, I'm suggesting you take a detailed history about what happened at recruit school. Now, I've spoken to some members who've had terrible things happen at recruit school, with suicide attempts or completed suicides and episodes of abuse occurring within their first weeks of entering the Defence Force. So it really is important to start right at the start and find out what happened to them, and then talk to them about their initial employment training and then their postings. That means where they've worked, what different units they've worked, and then their deployments. Now, deployments vary they're not all the same. You can be deployed on active service or warlike service. You could be deployed on humanitarian assistance or peacekeeping duties, border protection. So each type of deployment is different in its purpose and in its activities. It's not so much the number of deployments, it's more what happens on deployments. You can have a lot of deployments that go really well. You can have one deployment in which a lot of bad things happen to you, which are more likely to traumatize you. As mentioned by John, we've developed a paper and published in Australasian Psychiatry last year to go into the assessment of military and veterans patients in a bit of detail. And as you can see, this is a box from that paper, and it goes over some suggested areas to cover in your specific military questionnaire as you're learning as you're conducting your initial assessment. So mentioning about their deployment history and their trauma history. What happened prior to entering the military is very important as well. It's not just about military service. Remember, it's lifetime trauma exposure as well. What traumatic events might have happened, and remember, sexual trauma is an important part of what can be experienced. So it's important to ask about that as well. If you're dealing with veterans, then talking to them about their transition from military service. On what basis did it occur? Was it military? Was it medical? Was it administrative? Have they got legal problems? Talking to them about their Department of Veterans Affairs problems. Have they experienced homelessness? And also touching on other issues like substance abuse, very important, comorbid physical problems, often musculoskeletal injuries and chronic pain, significant comorbid problems, what medications they're taking, and also gambling. I recently saw a presentation by Sean Cowlishaw from Phoenix, Australia, who talked about not just the association between gambling and substance abuse, which I'm sure we're all probably aware of, but also some data, some studies from Phoenix, Australia, in which they're looking at a connection and association between gambling and PTSD in Australian veterans, which suggesting a significant association. So taking a gambling history is important. Family history has been touched on by some of the other speakers, their marital status, their effects, family effects on their service. Are they living away from their family? Lots of military personnel will take a posting for a couple of years at a time and leave their family in the old location. So their mum and the children might be in Townsville and they're away in Sydney for a couple of years, and they only see them periodically. I don't know how military personnel do this, but often families make this sacrifice so they can have continuity of care for children or education. Sleep is an especially important part of the history, as John indicated, and DVA problems, DVA claims invariably become part of the discussion during assessment and subsequently during treatment. Now, I recommend using screening tests when assessing serving members and veterans. Now, a lot of people are down on this. They say people never answer these reliably. Well, sometimes they don't, but sometimes they do. And particularly when they've made up their minds to seek treatment, they're much more likely to have meaningful responses to these tests. Here's a few tests listed here that I frequently use and in initial assessment, looking at trauma with the PCL5, the DAR5, which is an anger response diagnostic tool, the DAS21, and of course the audit. Now, people often say that the tests that people do on return from deployment, that nobody ever answers those accurately. And again, it's much more complicated than that. We've seen 200 patients at the Second Opinion Clinic at the ADF Centre for Mental Health. And as part of those assessments, we look at all their psychology files and their old medical records as well. And particularly in the patients we've seen who've been later diagnosed with PTSD, we look back at their return to Australia screens, and often in their first 1 or 2 assessments that they've completed, they have indicated elevated scores, which suggests subsyndromal PTSD, which, as you're aware, is a significant risk factor for late onset development of military-related PTSD. So people do often use these tools. They have a utility, and particularly in patients, military personnel, these are people who aren't good at talking about their feelings and describing their emotions. So use of screening tests can be a means to draw them out. You can ask them about the questions that they've answered. They can be used as counselling tools and measures of response to treatment, and you can include the results in your reports. Next, I also recommend using diagnostic confirmatory tests. A number of studies have shown there's quite poor inter-rater reliability amongst psychiatrists when they're diagnosing PTSD and when they're estimating its severity. So that's why I agree with some papers which have recommended the use of disorder-focused assessments like the CAPS, the Clinician-Administered PTSD Scale, or CAPS-5. So this gives you a great deal of diagnostic certainty and helps you rule out fake positives in high-risk groups like military personnel. The test takes about an hour. You can learn how to administer it yourself online, or you can ask a friendly psychologist or clinical psychologist who might have experience in this, in learning how to do it, in asking them to do it for you. Now, writing reports for ADF personnel. So often, this is a thing that puts people off seeing Defence Force patients because, funnily enough, referring medical officers do require clinical reports. Now, they need reports every within a couple of weeks of your initial assessment. But when things change, when their mental state changes, when the risk level changes, when you change medication, if you're a psychiatrist, or when you're changing therapy otherwise, and at the cessation of treatment. So if you simply comply with the College of Psychiatrists guidelines, you'll be doing very well. But I know that often specialists aren't immediately responsive. I remember doing an audit of patients in the Brisbane Metropolitan region, and we looked at about 25 patients with PTSD, and specialist reports were often late. And one particular patient who was extremely unwell only had one specialist report in a period of 2 years. And that was after a 3-month hospital admission. So I do recommend using proper reporting. Now, with regard to reports, don't get hung up on worrying about whether you're making accurate recommendations for the Military Employment Classification System, the MEC system. You'll often hear your patients talking about this. Don't worry about it. Leave that to the experts, which are the Defence Medical Officers. But with your reports, just make your regular recommendations about a person's fitness for work, either full-time or part-time, whether they're fit to go away to sea or an overseas posting. You need to advise on the likely effects of medication and on special duties, like if they're a pilot or if they're driving a tank, and especially whether they're fit to handle weapons. And in forming your view about this, remember to ask yourself, would you really want to serve with them? Would you like to serve under their command? And another way to improve the credibility of your reports is to talk to their treating medical officer to find out what are the nature of mental health services, for example. Can you go back a slide, please? The slides are changing by themselves. Thanks. Yeah, just leave the slide there. So I suggest talking to the patient's medical officer if they're wanting to go at 2C or on a deployment to find out what is the nature of mental health services available in that location. Remember, medical services in some of these places and at sea are going to be quite austere. So you have to be careful. You're going to have patients who are very keen to go on deployment. So you have to balance that out when you're making a recommendation. Now, there's a number of potential ethical dilemmas that psychiatrists and psychologists can face when treating military patients, and confidentiality is often at the top of the list. So I think you need to start your consultation with talking to them about the fact that you are going to need to write a report to their referring doctor, and that's going to include recommendations on treatment and their fitness for duty. So don't worry about having to talk directly to the commanding officer. Your role is to report to the medical officer. Let them deal directly with command. They're the experts in all that military medical administration stuff. But bear in mind that a soldier or sailor or airman or woman's commanding officers are entitled to information about their fitness to work, their fitness to deploy, and what duties they might be restricted in performing. And their medical officer can give the CO that information. But COs aren't entitled to information on the exact nature of the diagnosis or any other kind of matters without the patient's consent. So this dual agents, the other ethical dilemma is a dual agency or dual role dilemma, when the psychiatrist faces the conflict of responsibilities between the therapeutic relationship with the patient on one hand and the interests of the military on the other. So this is a long-held dilemma. If you're actually a uniformed psychiatrist as opposed to a private treating psychiatrist, then that dual role is really made explicit. And that dual role dilemma is really highlighted in wartime when there's a need to maintain the fighting force, and combat stress victims are that we need to return them to the line as soon as possible. But in terms of peacetime, that dual agency dilemma is much less frequently encountered, but I certainly do come across this. And some of the examples in which the duty to the military can still sometimes outweigh the needs of the patient. They're rare, but here's a couple of examples. For example, the first one is when the patient's condition is incompatible with military service when they want to stay in the military. And I can give an example of a patient I saw who just finished his training as an aviation technician when he had a first onset episode of schizophrenia. He had a very good recovery, but as you know, recurrences are likely, and the onset of psychosis is often very insidious. So in a safety critical role, it was very difficult for him to stay on in the military. Also, decisions on the duration of treatment because of the impact of the patient's fitness and willingness to deploy, they can be another source of concern or dilemma. And so an example would be a patient who's had a good remission from PTSD, for example, with pharmacotherapy. They've been in remission for about 8 weeks. They want to cease the medication and then go on deployment. So sometimes you need to state your case. The recommendation is that you would like them to continue on medication, present a case for them to deploy on medication to reduce that risk of relapse. So when I know that patients, they often, when they approach their treating specialists, your response is to want to advocate for them, but sometimes you have to ask yourself, is the report you're writing supporting just what the patient wants? Is that reasonable for the patient and for the military as well? Because of, in this case of the medication, the likelihood of relapse when they're in the field, which would be particularly disadvantageous for a member. So with regard to these sort of ethical dilemmas, military psychiatrists, psychologists, really we work both for the patient and for the Defence Force, and it's a constant struggle to balance the patient's interest with due regard for the safety of others and the operational effectiveness of the unit or the ship. Now, secrecy issues sometimes come up. Members or veterans report, look, I'm sorry, I can't tell you about this because it's classified information. It's so secret and I can never talk about it. Now, in my experience, this is a red herring. So I'm still a serving member in the Defence Force and have a reasonably high security clearance. But even then, sometimes we're not allowed to be told information because certain things have a need to know basis. So some people advocate that clinicians need to have a high security level so we can talk to patients who work in particular roles. But in my experience, this really isn't necessary, because what you really need to do is acknowledge the patient's concerns and reassure them that you won't ask about that secret information. What it really is about is usually the patient's reluctance to talk about extremely distressing events because they're going to be extremely upset by doing so. So in my experience, this is a bit of a red herring, and you just need to explain to the patient what you need to know for clinical reasons, reassure them that that therapy can work if they do require trauma-focused therapy, and that you don't need to go into tactics, techniques, and procedures. It's all about how they reacted to those events, how they felt about them afterwards. So secrecy issues can certainly be overcome. So how do veterans actually get mental health care? Well, very often they've got things sorted out before they discharge, but sometimes they don't. Sometimes they've got no contact with DVA and they turn up to a medical centre or a GP who's never seen them before. Now, it's important for GPs to realise that there is a special Medicare item number for a long consultation to assess if someone who's just left the military, take stock, do some screens, and find out about any physical or mental health problems. My understanding is that this Medicare item number is not well known and not often used, but so I wanted to plug that today. So this is for patients who still haven't got a DVA card, but there's certainly this Medicare item number for an extended consultation so you can begin that assessment process. So once they have made contact with the Department of Veterans Affairs, they can obtain a non-liability healthcare card or white card. And once they get this, then this pays for the entire cost of treatment for any mental health condition without the need for the condition to be accepted as a claim from the Department of Veterans Affairs. So it covers a wide range of conditions like PTSD, depression, even bipolar disorder, as you can see there. So who's eligible for a DVA white card? Well, anyone who's done 1 day's full-time service or reservists who've, excuse me, who've rendered reserve days in disaster relief operations, border protection, or if they were involved in a serious service-related training incident. So they just print the form and they get their GP or psychologist or psychiatrist to sign the form, and DVA claims that they can provide this card, approval for this card, within 1 day. So it's quite quick, quick turnaround time. Once the person has a white card, then all their future psychology, mental health, even private hospital treatment is covered by the Department of Veterans Affairs. So you also need to know about claims for a mental disorder to be accepted as a liability. Now, they take a long time. There's lengthy forms for them to fill in. There's reports for psychiatrists and psychologists to fill in. And it takes a long time before their claim for liability to get compensation can be decided upon. This can take several years. But veterans don't need to wait for those claims to be accepted before they can apply for an incapacity payment. This has been going on just the last couple of years. An incapacity payment benefit can be processed quickly. The claim for this one can be processed quickly. They just need to get their GP or psychiatrist, provide a special DVA medical certificate, and then they're entitled to 41 weeks of incapacity benefits, which in the past has often been enough time to get their liability claim assessed. But I'm also mindful, and my patients are telling me that processing of DVA claims has greatly lengthened in the last 12 months. So there's a potential difficulty going to arise there in the near future. And I think they're likely going to have to increase that window in which incapacity benefits can be paid. So that's my presentation, and I'm happy to field any questions now or after Nick's presentation. Helen.
Okay, good. Thanks, Dad.
Where are we going to go? My slide. Cool. Cool.
Thanks, Duncan. That was sensational. There was one that I wanted to pick up on. My background is policing and in counter-terrorism policing. So I've trained with the military SAS in relation to it. And when you said about, would you serve with that person? We've had people in my section which I go, my gosh, how do I serve with this person? They've been assessed by a psychologist as being operationally fit. But when you talk to anybody else in the section, they'll go, oh, he's got some quirks, he's got some idiosyncrasies. And then you say, but would you go into a stronghold with him as your only backup? They then go, oh, not. As soon as it goes questionable, then there's a doubt and you can't do that. If you've got someone where you go, I'm not sure if I'd like to serve with them, but they've been to see the psychologist, where do you go then? How would you manage that?
Yeah, well, often we do see patients like this at our second opinion clinic. I think you do need a second opinion, and it's obviously in my position, I'm able to provide that with a long military history myself and an understanding of the organisation. So I'm pretty well suited to that. But it's difficult when you send them to another civilian practitioner. Look, a lot of the psychiatrists and psychologists that defence uses are very experienced. And so using someone like Nick Ford, who's with us today, would be an excellent person to seek a second opinion. Now, remember that often your information comes just from the patient. So when we do second opinions, we also get a wealth of documentary evidence on their psych file or their medical file. So the more evidence you can provide to put in front of the person giving the second opinion, the better. But then it does come down to the psychiatrist's willingness to confront the member a little bit and to disagree with them. As I said, there's a willingness to want to advocate for our patients. And I have had a few complaints writing second opinions, and often this comes about when people disagree with my recommendations. I'm saying they're not fit to serve. They've seen 2 or 3 civilian psychiatrists, and they've all said yes, they're fit to serve. And often they didn't have information that I had, and it's a question of whether the civilian psychiatrists or psychologists are willing to press them a little bit about it, willing to get that extra information, and willing to then talk to them about the likelihood of relapse and the risk of exposing themselves to further trauma, and whether that's a good decision or not to actually make. So it's a very difficult situation that you mentioned. Thanks for the question.
Hi, my name's Nick Ford and it's lunchtime. So what I'm going to do, raise a couple of points, and I'm going to give you a puzzle to think about over the lunch break. My bio's in the thingamajiggle there, relatively limited. I'd particularly like you to note the coaching of the Ashton Rangers junior under soccer team. Very happy time. So I'm a primarily clinician. I do a little bit of research and a little bit more teaching, and that's the audit over the past 12 months. Now, notice an interesting thing where we look at psychiatric disturbance across all of the services, and it turns out I've seen 2 firemen, 2 paramedics, 50 plus police, and 100 plus veterans and military. Have a think about why that might be so. Now, moving on, all of this case material is presented with the patient's permission. So here's a thing that I'm currently dealing with. I saw this chappie for the 2nd time last night. Maybe that's a clue. So he's a 45-year-old high waiver patrolman, which means he carries tasers, capsicum spray, weapons, and drives a vehicle capable of going extremely fast. He said to me with a very pronounced startle response, and he really was jumping out of his chair, agitation, anxiety, and anger. A lot of the anger is toward his daughter, who we know has just recently got her P plates. Ex-Army Special Forces, which means he's as alpha as they come. And no deployments. He says he's fine. His work is fine. His wife and nurse practitioner who recommended he see me don't think so. He wants to go back to work. So I'd ask you to think about over the lunch break about whether that should happen a few days after I saw him for the first time. And if you don't think he should go back to work, how are you going to tell him and persuade him that that's the case? So we'll resume in about, 20 or 30 minutes, I imagine. And I will segue back to some of the excellent presentations because there's some points I really want to underline that Miranda, Karen, John, Duncan have raised already. See you in a bit.
For those who are online, we're now going to take a 30-minute lunch break.
We're going to recommence in 2 minutes.
Oops. Okay, hopefully you've had a bit of a break and feeling refreshed. Look, I just wanted to go back on this morning's excellent presentations and a couple of points that have come up from the speakers that I really want to reiterate. these guys and girls, they like a framework for treatment. They like an explanation and they like benchmarks. Now, benchmarks can be fluid, but they like benchmarks. Loss of control of your mind is a terrifying and frightening thing. But the reality is these conditions have been described for at least 2,000 or 3,000 years. This is nothing new. And sometimes talking about that, about the background, can be helpful. Family engagement early. Usually by the second, sometimes the third session, I have the partner or wife, parents in there talking about what their observations are. And that is really valuable. So that goes back to Karen's work. Physical issues, musculoskeletal issues, really important, which was why we have Jacinta here to talk to us about that. And the other really key issue is early identification of symptoms. The traumatic stress psychological disorders have a pattern, and picking up on anger and sleep disturbance early in the dude's career is really important, because otherwise what people like me are dealing with is somebody 55 or 60 who's retired from work, probably separated from his wife, almost certainly has a substance abuse problem and completely not engaging with the community. Whereas now what we're seeing is a whole bunch of guys getting back to work and getting their lives back. So anyway, my friend here, now there's a way of doing this where we ask for questions, or we can do it the way they do it done Troon, is I start from left to right or right to left and just ask people individually. So volunteers would be welcome. What should I do? Should I let him go back to work? If anybody puts their hand up. Oh, we could ask the online people as well. I will tell you how to revolve. Ivan, remember I said about the Duntroon way? What are your thoughts? John's moving in.
John?
Volunteer, good.
Really, really good question. And so my first question to him would actually be, what do you think your boss would say if he knew about you and what was going on?
Now, obviously I've got a lot of background with this, so I can actually tell you how that goes. As far as his boss knows, he says the boss is quite cool with him at work and doesn't know anything about this. I'll let slip a little bit something there because I had his wife come in to the session. She says the boss is quite worried about him because of confidentiality issues, and then we permeate into the command sort of area. I can't actually ring the boss up and say, what do you think about him yet? Excellent point. Go. Yep.
I'm just doing a layperson's comment. Just
But
knowing
you,
my
you work with my patients, so I know who you are.
just with my veterans, I would definitely be just listening to his wife. The anger thing, yeah, I'm probably going to get angry when my kids start driving too. So I'm not really relating that to anything, but definitely listening to the wife and the nurse practitioner.
Yep. So if I tell him what to do, this is the first time I've met him. He's driven quite a long way to see me. If I say, mate, I want you to do this, this or that. I'm a stranger. How do you think that's going to go down? No. He's fine. Being on the road is his happy place, he says. His wife has a geolocator. She knows he spends a couple of hours sitting in the same place by a river every day. Good point. Don't know, didn't ask. He may be.
I'd be interested to know his reasons for leaving the Army Special Forces. The fact he's ex-Special Forces but has no deployments would be an anomaly. Yeah,
really good point. He was scheduled to go to ET. They were all going over to ET. He was in a training role and they wouldn't let him go because they thought he was doing a good job in training. He said maybe that he wasn't deemed up to scratch. Who knows? He got annoyed. He'd been 10 years in the Army at that point and left. So let me tell you how it went down. We had the usual discussion about stuff, about what I was thinking was going on. It was made a little bit easier because he was referred by a colleague of mine, a guy called John Schumann, who I worked with a little bit. So I had a little bit of cred even beforehand. And I could have said a whole bunch of things about this is what you're going to do. Instead, in a cowardly fashion, I said what I thought needed to happen and he'd like him to think about and have a chat with the wife overnight. They rang me the next day and said, okay, I'm going to take a week off. And yes, I'm happy to put this on work cover. And yes, I'm happy to speak to the early intervention coordinator. Now, think about that also, because all of these emergency services workers, mostly we're going to talk about the police today, SAPOL, the FARES and AMBOs all have early intervention coordinators, and they become a really useful access point into actually managing the patient in the workplace. So that is handy. So they rang me back. Fortunately, he made a really awesome response to Topamax to drop some of the startle down. I was switching his antidepressants around. So phases 1 and 2, because we do have benchmarks, we operate this. I gave him the usual talk about this situation. And in my case, I'm using a lot of medications because by the time people get to me, they've usually seen 2 or 3 other people, usually a couple of really competent psychologists. So we use that. Yesterday, we had a whole bunch of stuff and I gave him a whole bunch of tools about managing anxiety and distress. I put him onto the ACT Stoic. I gave him a little exercise I have called smile harvesting. We talked about some of the disabilities that you can expect. We've already started liaising about early intervention, return to work. We have a deal. At the moment, he thinks he has a deal, which is 3 non-consecutive days a week, 6 to 8 hours a day. What he's proposing is 6 hours on the road and 2 hours typing. Now, we're going to continue to haggle about that over the next week, but I'm having all of these conversations with his wife. Next phase is going to be liaising with the senior sergeant, who I think is quite across all of this, and that'll happen via the early intervention coordinator and rehabber. And we'll put him in some limited duties, very likely. One of the really important things is to maintain this guy's pride, his sense of competence in himself. And doing that gingerly while, kind of turning him into a patient is something that's got to be done really delicately. And once we're through that phase, we're just going to gently chip away at some of the trauma issues, and there's quite a few that have been mentioned already. And in that process, I'm probably going to ask a psychologist, a couple of whom are in the audience here, as to whether they can help. Now, my little dongle is just broken here, which gets back to another situation, is why am I seeing so many cops and not so many paramedics and fireys? Now, one of the issues that comes up is the fireys are a very tight culture. Their workload is intense, but they are on only sporadically. But they have a very tight culture. They are spending a lot of time in their stations talking together and debriefing themselves. They also have excellent psychological support, one of whom you spoke with earlier today. The paramedics have a degree program now. They do have APRA registration, so that's a threat for them. Their work is heavily guidelined. Best of all, they have a narrative. They know what they're walking into from the get-go because somebody's always there beforehand. And they have a narrative, they have a thread of what's going on. And on a good day, they're liaising with the emergency doctors and they're getting their patient alive to hospital, and that will be useful. They also have an excellent internal peer consultation service run by a guy called Joe Magliero, who got an Australia medal for that. And the fact that he's one of my best friends has got nothing to do with mentioning him. And that has been running for a good 20 or 25 years. So that's really awesome. Police are at the ground stages of that. It used to be Army and police were neck and neck, may I say, at the bottom of the barrel. But police are now exceeding Army in terms of that psychological rehab. And we'll get to some of the factors that are involved later on, because I'm on a timeline here. When we get these guys in, and obviously this is a busy practice and I'm trying to be efficient, the aim is functional restoration. This might involve work cover. Now, the minute you start talking about workers' compensation, you've lost track of what you're on about. The minute you start talking about compensation, people don't want compensation, they want their lives back, which is why Return to Work SA, and it was called the Return to Work Act. This is about recovery, not money. There are early intervention coordinators and they're really helpful. Sign off with police will be by the police medical officer and psychologist. Now, it was an interesting thing to me that to find out that I'm sending all this information, let's say, to injury management, the police psychologist and medical officer until recently never got it. So they're just operating cold and making decisions with no communication from me, which is appalling on my part. But in fairness to me, I didn't know that was happening. Now that's actually been changed. How that will go with this particular fellow, I don't know, because I'm aware of who he's going to see. I'm aware they're quite risk averse. And so I don't want him feeling punished and trapped by the system early on. Return to work SA has a particular set of issues. Legislatively, and not every patient goes through the Return to Work SA Act. There's a few coppers that I see who have other issues and some choose not to. The significant cause. Now, legally, that means all other causes must be trivial. Now, it used to be 10 or 20 years ago, there'd be a whole bunch of legal argument about this as to whether the guy's dog dying was the cause of the stress of this guy who'd, say, rescued somebody from a burning car. That argument has largely ceased, and we're actually seeing really good results. There are some particular issues where it becomes a problem. Claim determination can be awkward. There are insurance medical examiners. A lot of these guys are my colleagues and acquaintances, friends. There's always awkward issues, but mostly it's done fairly. And then we look at return to work staging, and I've given you a bit of a glimmer of that already. Sometimes there's a psychologist involved. My job is to diagnose, come up with a problem list, maybe implement some medications, and then start talking about return to work in a way that we'll get to in a tick, because there's a few things to think about in that space. Now, because I'm short of time, or you are, I'm going to zip through some stuff. So here we are, a couple of points. This is Ferdy, who presents with depression and marital separation. And his entrance into hospital was, after I'd seen him for a month or so, was precipitated by a known OMG affiliate sitting outside his house having a cigarette. And that made things a little bit twitchy for him. Now, 3 years prior, in a fracas with an offender, and we'll hone into that, the offender had seized his weapon. We'll get into that in a little tick. The wife's pregnant at the time and an 18-month-old son. So a couple of things. He moved from patrols, general duties, to CIB. And the particular issue there was he wanted to avoid violent confrontations because, of course, if you get killed in a fracas, your life's not your own anymore because you've got kids and a wife. And so that was fairly nervous to him. So that transition really becomes awkward. There is another issue with this that came up that was really handy. In the fracas, in the discussions that we had, the offender was coming at him with his hand raised if he shot the offender, and we'll talk about the importance of that. And the offender has a weapon, that's fair. If there is no weapon, it's manslaughter, criminal charges. So while he's thinking about that, over the next half a second that he's got, the offender's grabbed his gun. He's rolling on the floor, fighting the offender, and he says to me, "I enjoyed fighting." And in a very guilty and admonished turn, remember he was severely depressed, he said, "Does that make me a bad person?" And my comment at the time was, it's actually really handy to have someone like you around. But remember the guilt and the fear of loss of control that can come up with these guys. Now, think about some stuff with police. It is a hierarchy, much like Duncan was talking about. There is a command structure. Think about why the guy is there and where he actually is. For example, country police tend to have a very high work schedule. The accidents happen at higher speed, and the people that die or suicide are usually people who the guy knows. So that can get awkward. They also like to stay out there because the country's nice. So winkling them away from that is difficult. And often there are regional stations with a big central station, and there are issues associated with that. Socioeconomic demographic is tricky. Some suburbs are simply more dangerous than others. Now, an issue that can come up there when you're seeing repeat offenders is contempt. And once you start feeling contempt, the next step is anger, and that can move on to other disciplinary issues. And someone needs to be mindful of that. Current priorities. Individual, kids are a big one. And social issues, now often with police, they're media or politically driven. So people are being driven to undertake particular taskings, which they may or may not see as relevant. Comment I particularly like is that throughout the world, there are usually men doing dangerous jobs that the nation needs done. That's what we're dealing with here. And what exactly do they do at work? Country policing, great job, got its issues. anything to do with child porn, anything to do with kid abuse messes with people, anything to do with major crash. Undercover work is interesting. You can only do that for a short period of time because you lose your identity and lose who you are, and that also can be awkward. So here we have a guy who actually did really well. No medication whatsoever. A very clever psychologist called Leanne McKenzie and Victor Harbour did all the work, and I tried not to take any credit. CIB, one of the issues he got heavily involved in was the rape and murder of an adolescent. And one of the issues with detectives is the contact with the victims is prolonged. They get to know the person in some detail. So that was really hard for him. So what happened with this guy was we sent him back to work. He wanted to go from CIB to uniformed, perfectly fine. A lot of doubt, a lot of uncertainty about whether we could do that. He went back, he went into the station and stayed in the station for about 2 to 4 weeks. Then we started sending him out on patrols only with the senior sergeant. That graduated to any other officer. And we kind of knew things were good when he was in a pub and he had 3 young blokes in his face telling him he was a bad person in all sorts of interesting ways. And he maintained composure and maintained a professional demeanour through it. Now we've moved him up to return to work solo patrolling. In fact, he was running a small peripheral country station for a little bit. We're still working out how we're going to deal with issues about dead kids and such like. So now we have to think about control over outcomes. Now, police can arrest and do all sorts of things as much as they like. That doesn't mean that the magistrate will take that through. So often they ignore what actually happens second. They'll often ignore the final judgment. And I think it's fair to say sometimes it depresses them. Scrutiny. There is a high degree of scrutiny of police. Now, I've been in a few countries where there is no control over police, and you certainly see things getting pretty messy there. I remember being quite nervous leaving Tashkent Airport, but in other places like here, possibly that control is a little bit too tight. Criminal disciplinary charges, later internal investigations. Now, one of the entry points into internal investigations is because you've done something dumb or dangerous. And often that's led by post-traumatic stress or a psychiatric condition. So then you have the issue of working out, is he saying he's got something wrong? Was it something wrong? And Internal Affairs, I believe, are looking at that at the moment. And then you have strange situations like the Sturt 6, who I'm sure you've heard of, 6 policemen who were charged with stealing stuff from a drug house. Court case went for 4 or 5 years. They were off work. Off work means, by the way, a 30% reduction in salary. So that was messy for them. $30 million of court fees, and they were all found not guilty a couple of years ago. So you have issues like that arising. Physical fitness and health. Army have to do basic fitness tests all the time. I think the fireys are pretty fit. Ambos tend to be fit. Police do spend not as much effort as they should on that, with the exception of Staff Force. There's also a certain amount of sitting around in cars waiting for something to happen. So that becomes issues. Shift work, substance abuse, training and tactical defence and control. Ideally, your violent offender can be restrained with various arm locks and such like that, and things are done smoothly. To maintain that proficiency, and both my wife and I have been ex-martial artists, you need to be practicing that stuff 2 or 3 hours a week. Our police get 2 hours a year. That makes you a little bit twitchy about those engagements. And then you have to resort to your next tactical options, tasers, capsicum spray, and then guns. And once you start using those things, there's all sorts of issues that happen in terms of subsequent investigations. So there's a lot of immediate anxiety with what you're actually doing. And the opportunity to personalize victims. Never look in their eyes. And that becomes very challenging for people because we like to be empathic, we like to understand. That's useful, particularly good in de-escalation situations. But once you're starting to identify with that person, once your shields are down, it becomes quite an issue. Am I going too fast? Probably. Nope. So here we have another situation. So this lassie, and all these people are used with their permission, is sent to see me for a fitness for duty assessment, which is a pretty threatening thing. She has a fractured ankle. She's got no recall of how this occurred. But it turns out she's having dissociative amnesic episodes where she's getting up, checking the curtains, running around the house in the middle of the night, no memory of these things, plus turns out she's having them during the day. Turns out she's first on scene after an abduction where 2 young women were taken. They were going to be raped, beaten, possibly killed. She met the first of them, lots of blood, lots of noise. Turns out that she was a backpacker herself at one stage in her youth. She was keen to have nothing wrong with her, and she was really annoyed with me, quite distressed, because I said, I don't think you should go back to work. And one of the comments I made was, I don't want to see you here in 5 years' time, a total wreck. It's kind of nice because she sent me a thank you card 2 weeks later, but I'm not sure how her career's gone on. So her presentation was covert, and she was keen, as Denise was saying, to minimise any mental health issue, but she certainly had it. So here's a couple of useful things. The police have an annual IMOS test. Now, as a way of gauging startle, rage control, it's awesome because you have to wrestle with people, you have to use a baton. People will soon see if you're out of control with a baton. You also have to fire guns, so that's a great test for startle, and you have to move into a kill house, where you shoot the bad guy, don't shoot the hostage, and move your way through. Very handy. And you see people fail on that when we've been certifying them fit to return to work. Well, that's the final test that we usually put in place. The other cool thing is if people have been off work for longer than 6 months, they have to do a 2-week reintegration course. Now that includes IMOS, but it also includes a whole bunch of stuff about legislation, de-escalation, tactics. The handy thing about that is the police officer's confidence in his knowledge is being restored, or if there are deficiencies, they're corrected and monitored. Now, credibility and trust, this becomes an issue when you've got commanders. So you have, let's say, a sergeant or a senior sergeant, his team knows he's gone off work with an anxiety condition. How is he going to get cred with the team? Often we move them to another site, but sometimes there's no option. That's often because they have really good relationships with the team. So a conversation I had earlier this week was stop thinking like a patient, start thinking like a police officer. And shifting him into that role. He's quite shocked that he got back to work. I think we're all shocked and pleased. And one of the useful things, of course, is that a psychiatric condition, whilst not inevitable in a policing career, it's likely to happen. So what I've been saying to this guy is you're giving them a role model of how to get back on the bike again. And we're working our ways through that. Now we're going slowly. He's doing a little bit of project work around that particular station, but he's engaging with them. They know he'll be back bossing them around, I think, 2 weeks' time. But that whole thing is fluid. And escalation of duties and observations important as well. How am I doing for time? Nearly there. Now, I got pinged at the last talk because I threw in some neuroscience, but one of the things I did at uni was an honours degree in biochemistry, so you're going to have to put up with this. You're not one person. Your brain will fluctuate between different sites being activated when different tasks are being performed. Now, all of you are listening intently to me, so your central executive network is activated. A couple of you might be looking at those pictures over there or thinking about what you're going to say to the kids. Your default mode is activated, and that's pretty cool. Ideally, all these networks in their function should separate cleanly from each other. You go from one to the other. Psychiatric illness is just simply crosstalk between those networks, or that's one way of thinking about it. So a couple of points that happen with trauma-related disorders. There is a dominance of the fight or flight circuitry. Ideally, you should be alarmed and frightened, then come to a plan, usually instantaneously, and shut it down. Let's say you're walking in the hills, there's something long and slippery in front of you, you freeze. That's your fight or flight circuitry kicking in. Then your central executive network will kick in and say, oh, it's a piece of sassafras, or goodness me, that's a King Brown, and you'll start working actively. In these trauma-related disorders, the fight or flight circuitry wins. Executive processing is diminished, really tricky when you're trying to do work that involves detail and paperwork. So there is concentration and short-term memory impairment. You won't pick it up on a neuropsych test because they're really kind of, not gross is the word, but they're not designed to pick up those nuances, but those nuances become important in these highly functional situations. Another really important bit is faces are seen as more judgmental and rejecting. Now, as humans, we're really sensitive to faces. We can read faces and read people. The fight or flight circuits are taking over. People are seen as more judgmental, and that's the basis of the neuroimaging studies. That's how things are done. Trouble with that is your affiliation networks are compromised. Your ability to relate, to trust other people is compromised. Even worse than that, because you're walking around looking shifty and miserable and depressed, people are going to be nervy and shifty around you as well. So that becomes a self-reinforcing cycle. And one of the things that is helpful to do with these guys is actually run through this circuitry. Increase sensory input. You've got a little janitor in your brain centered in the insula about there, monitors all the stuff that's happening in your body. That's normal, that's not normal, and I'll ignore it. Now, the trouble is that starts to break down with psychiatric conditions. And the other thing is your pupils are dilated, your retinas are picking up, so you are literally deluged by data, which is one of the reasons people have difficulties, like my patient, in shopping centres. Too much data, too many angry, nasty people floating around. All of this is experienced as a grumbling disquiet, an easy startle. And then on top of that, you can add the dissociative flashbacks, et cetera, et cetera. And once you've gone long through all this stuff, you're going to wind up getting depressed because your brain is simply worn out and exhausted. I've got a little circuit diagram I draw patients, and oddly enough, they get it. Remedies. Shutting a lot of these things down with medications is important. Teaching coping skills so the patient's got something they can go home with. There's a whole bunch of useful apps. Actually having the conversation in the room is valuable. So we look for a graded increase in threat, confrontation, detail, and information. And in that regard, you can't control absolutely for threat confrontation. You've got to wing it a little bit, and things go wrong. Largely they go right, but you've got to be fluid. And the usual sequence with a base policeman is office, in the office, answering the phones, doing paperwork. Now that is demeaning in a way. On the other hand, you're doing the stuff the other guys don't want to do. So they're kind of happy to see you back, and they're very often supportive. Then you move out to the phones, maybe dealing with some hostile offenders or people who've lost their cat in a tree or whatever. A little bit of thinking on the job, then the front desk, then patrols, going to court, investigations. All this, by the way, is based on the idea that organisation's got your back. Because if the organisation doesn't have your back, that's tricky. And that does happen sometimes, certainly with some commanders, and internal affairs do create issues. Mind you, I gather they're better than they used to be. So maybe those rude letters have helped. Sometimes steering away from triggers, usually they're around kids and sexual assaults. Now, this process needs to be actively managed. Remember, these guys are busy guys, they're focused, they want to do things. And at that point, I usually tell them the story of my 2 knee reconstructions. Big knee reconstruction, 3 months later, I went surfing. That didn't work out well. So that's a useful little tidbit. I'm sure all of us have got our little stories that we throw in to illustrate points to patients. Too fast, the flashbacks, agitation, sleep disturbance increase. But too slow, feelings of humiliation, being useless also increase. And I've been caught both times by being too fast and too slow. Oddly enough, too slow is the one to mostly watch out for. So I've taken 5 minutes longer than I should have done. So unfortunately, I'm going to have to skip some bits about, oh no, I'm not. Paramedics. Paramedics, solo or part of a team. It's now a degree course, high selectivity, hierarchy of skills, all the way up to intensive care paramedics. These are guys who can cut your throat and put tubes in there, all sorts of clever stuff. Lots of scrutiny, relationship with other health professionals. Emergency physicians really like to deal with. Are so focused, quick in their thinking, and very affable guys. Joe Magliero again. APRA. APRA has been criticised by 6 successive Senate reviews. That's another topic. I've got a publication on. They are a very poor organisation. Ramping, mental health and assaultive patients really cause grief. Mental health is hard to quantitate. It's hard to have guidelines as to how you're going to manage that. I think you've got a good narrative. There's a sequence. Here's my patient. The police are there first, and they've done the scene control, and we are working our way through a process. And graded return to work duties are available. Fire is slightly different. no greater return to work. You're either fit to go out in the truck or you're not fit to go out in the truck. The work is sporadic, it's unpredictable, but intense on periods. By the way, they pack the bodies up when people have died too. It's an interesting thing. Physical fitness is often high, and they tend to have a tight team relationship. Now, the other thing about them is increasing technology and the need to stay current. There's a lot of more complicated kit out there, and the older guys are struggling with that. The other thing is physical fitness, because you've got to be quick. If you're out there and you're putting out a fire and suddenly the fire is moving towards you, or you left your hose there, you've got to be quick on your feet to get out of that situation. So as you're getting older, you may be losing some of that fitness, and then you've lost your nerve, so to speak. Presentations tend to be late in the life cycle, is my experience. I would defer to my colleague Denise Keenan about that. And lots of suppression. Nothing wrong with suppression, nothing wrong with putting things to the back of your mind, and internal debriefs. And where are we? Oh, we've done that. So at that point, I'm just going to wrap up and have any questions fired at me. Anybody know what Maremma sheepdogs do? They live with the herd of sheep. The sheep play with them and they play with the sheep, but the sheep really know it's not a sheep, and the dog really knows it's not a dog, but it hangs around doing sheepy things. But if a wolf comes along, it's bad luck for the wolf. And that's where these guys sit in. So thanks for that.
Nick, we've got a question.
Oh, yeah, I've got questions from the online people too. Yeah, sorry.
Hi, Nick. I've just got a couple of questions. One of the things we're hearing a bit about is moral injury in ambulance officers at the moment, obviously given ramping and resourcing issues, which is increasing response times. Are you seeing much of that?
We've always seen it.
Yeah.
We've always seen it. PTSD is a fear-driven disorder. Rarely see it. What I've been seeing for 25, 30 years is helplessness, horror. I wished I could do more. The resources aren't available. Yeah, it really messes with people. And when they like a plan, and I'm sure there are plans being developed, but
yeah,
I haven't heard of them.
The other thing I found actually really interesting in it, I'm doing, as you know, I've been doing some work over the last 6 years on assistance dogs for veterans with post-traumatic stress disorder.
Yeah.
And one of the really interesting things we see in that is that there's the change in how the veterans viewing the world. So they're going into shopping centres and like you said, the people with PTSD in particular are viewing faces and people as being dangerous, judgmental, rejecting. Whereas when they have an assistance dog, when they go out into the environment, there's a change. So the people coming towards them are smiling, smile at the dog, they look at the person. But what it got me thinking about is I wonder whether that the process of how the dogs are working, because they are, so we've got now longitudinal data that show there's been massive sustained reductions in all kinds of symptoms. I wonder whether that's actually something happening neurobiologically. So because they're viewing the faces as less judgmental and they're getting that feedback, whether that actually causes some fundamental change in the brain, which then leads to the sustained impacts on symptoms.
Look, I so think you're right. The aim of the game with our patients is to get to that level, medications, talking therapy, assistance dogs, whatever. I think there is a fundamental change in the brain. Almost certainly it happens at a circuit level with the neuroimaging data. Whether it happens as a genetic level with epigenetic mechanisms, I don't know. Stacey and I and another lass tried looking at that a few years ago, but the data got lost anyway. Yeah. There's a really interesting study which involves, if you look into your dog's eyes, you will pump your body full of oxytocin, which will make you feel good. Now, I think that's hilarious. It's useful, but I think it's hilarious. How do they get funding for that? So cool. Yep.
Yeah, interesting. Anyway, yeah, thank you. That was.
And thanks for your input to all of you today. It's been really good and valuable. Yep.
Any further questions? Any questions online? Okay, those online, if you have any questions, please feel free to type them in the Q&A in the room.
I was just connecting with one of your case studies with the woman who sprained her ankle in the middle of the night disassociating. Yeah. And it just reminded me of a case which I was reflecting on the impact on the child. A similar situation, a woman police officer was disassociating and she was seeing the people from her service in the night. She would actually visibly see them. And so she would sleep with her child to protect her child from these people that she thought were coming to get her. And so, but this lasted for the child was an adolescent. So it started when he was a baby and it went right through to him being an adolescent. And she felt she could not sleep in his room and protect him. So yeah, these things play out.
They do. Yeah. Look, I have 4 patients who see ghosts, who they've been connected with in their death some way. And, you know, you can say, well, that's a hallucination, blah, blah, blah. But usually what I do is I do that and then say, what are they here to tell you? Yep. That seems to work well. Thanks for listening, guys. I'll leave you to it.
Holly, were there any questions online?
Fabulous. All right. I am not a seasoned academic presenter, so I do need my presenter notes. So I have them in front of me. So you'll bear with me as I make my way through 2 different screens today. But essentially, I am here to talk about, I guess, the other half of health, which is physical health. And our mental states, as we all know and have experienced, show up in our body. They are interconnected. And at the end of the day, you know, without our mental health, we don't really have any health at all. Our mental health dictates our whole experience of health. But I love that we can use our body and use our physical health as a way to influence our mental health because of the bidirectional relationship. So just tying in the importance of physical health and exercise, particularly in this population of military and first responders. So overall today, I'm going to try and not make it too academic. I got told to do a bit more of a case study type presentation, but I'm succumbing to my identity as an academic, and I've got some stats in here, hence the need for notes. But yeah, so we're going to go through a little bit of the physical health snapshot. So like, really, why is this important and why are we hearing so much about exercise and why these groups? And I'm probably more so going to refer to mental illness as a broader term as opposed to PTSD specifically, but I have tried to make some specific references where possible. We're going to deconstruct exercise, particularly exercise as a lifestyle intervention. So again, trying to mitigate these risk factors. And then looking at the evidence base for yoga. So my PhD, sorry, I haven't even introduced myself. My name is Jacinta. Nice to see you all. I'm an exercise physiologist, and we've got a couple other EPs in the room too, which is nice. I work at the Adelaide Clinic with Nick, and I also work in private practice, and I'm also finishing my PhD in my spare time. So my PhD looks at yoga and mental illness, specifically yoga through the lens of exercise science, not through a psychotherapy lens as well. So yeah, let's get stuck straight in. So let's have a look at the physical health of people with, or particularly of veterans. So veterans so severe pain is actually 40% greater in veterans than what it is in the general population. And pain is typically the #1 reason that people are presenting to primary care. PTSD and pain are frequently comorbid, and there are actually some theories in the literature that offer explanations for this bidirectional relationship that we do see. So I'm going to very quickly go through them, but there's the shared vulnerability theory, which is in the face of a traumatic event, some individuals have a higher risk for developing disability compared to a more resilient individual. There is the mutual maintenance theory, in which PTSD and chronic pain reinforce the chronicity of each other. And so the hypervigilance that you see in someone with PTSD elevates potential threats, and pain serves as this ongoing threat that elevates their hypervigilance. And it's just this nasty feedback cycle. Then there's also another theory, and I mean, to be honest, who's saying that all 3 of these theories aren't all occurring comorbidly, is that altered central nervous system sensitivity because of their PTSD symptoms can increase their nociceptive signaling. So that's your pain signaling essentially, and amplify the subjective pain experience. So whilst the exact mechanism isn't known, evidence supports many common neurobiological processes and neuroanatomical structures between pain and PTSD. And I think that is absolutely fascinating. And I'm shocked that I didn't know that before researching for this presentation. So there's some meta-analytical data by Benedict and colleagues that demonstrates that certain health outcomes as well, so pain, depression, physical function, disability, sleep, pain catastrophizing, pain self-efficacy are consistently worse for veterans with PTSD than when compared to the general population, and that many of these effects even remain after they control for depression, which is phenomenal. So this is something to be mindful of when we're treating pain in someone with a PTSD diagnosis. And then it's unsurprising to see that there are much higher rates of cardiometabolic disorders within this population. So in fact, we have data that shows patients with severe mental illness are at 85% higher risk of death from cardiovascular disease and twice as likely to have diabetes than those in the general population. So before we actually go into this, I just want to say that the life expectancy gap, so we've got some data on this, and you're probably mostly all aware that people with a mental illness do face a 15 to 25 year reduction in life expectancy than someone in the general population, and that this is largely attributed to modifiable lifestyle factors. So these are things like physical activity, sedentary time, diet, smoking, substance use disorders. All things that can be addressed and that have been shown to be efficacious for not only their physical health, but also for their symptoms, both PTSD and depression. So it really comes back to rethinking a treatment model, and we've got heaps of data, and I'm not going to try and get too bogged down in it, but whilst we've got, you know, your traditional mental health treatment, which is your like 2 orange boxes at the top here, we also need to think that medication has these side effects quite often on our physical body, and that these need to be mitigated and addressed. And there's some really cool data out of New South Wales. There's the Keeping Body in Mind program, where they put early intervention psychosis program, and when someone came in for their first like prescription of clozapine, for example, they would also see a dietitian and an exercise physiologist, and they compared like their control group to their intervention group, and their intervention group actually mitigated any medication-induced weight gain. Now, I know when I'm in the Adelaide clinic and I'm seeing patients, and there's even data that says 85% of people that are on an antipsychotic medication, it's their main reason for showing up is like, I want to lose weight. Like, I'm sick of, I've gotten so fat so quick and everything hurts, and now I've got all these body image issues, and this is affecting my mental health. And unfortunately, the data, you know, if we are starting them exercising at the start, we can have a good effect, or we can prevent any more weight gain. If we're starting them, you know, if they're coming to us for exercise and they've already been on medication and they've already, you know, experienced that weight gain, whilst we may not actually be able to reduce their weight just because of the effects of medication, we actually do still see changes in their physical fitness. So this is their VO2 here, that even though we're not going to see changes in like waist circumference or anthropometry, they're still going to have improvements in their cardiovascular fitness. So we still actually get those benefits, even though visually they aren't necessarily going to see them. And even though their main sort of driver is going to be weight loss, it is also just helpful to have that conversation that, you know, while you are exercising and you're not seeing these visual changes, you know, your body actually is responding and your body is getting healthier, and this is going to help your mental health, and trying to sell exercise a little bit more as this like medication pill, as opposed to a more of like that superficial fitness industry, like exercises to make me look fit, as opposed to, you know, I want to feel better in my body. So it's the whole solution, I guess, that we hear about, and it sounds really simple, but it's just like, we'll exercise more, just do more. Like, we just need to get people exercising, and we have a buttload. Like, if you search exercise and mental illness in Google Scholar, there is a buttload of clinical trials that have been done. There is a buttload of systematic reviews. Our real issue is just getting this like translation into clinical practice. It's really not as simple as just saying exercise more. I mean, people are presenting with like complex musculoskeletal issues going on, pain that goes alongside that, you know, weight gain, all these reasons that they can't actually move more. They don't know how to move more, and how to, you know, change their behaviors, even if they are really motivated to do so. So I just want to briefly touch on depression, because this is probably, motivation kind of goes hand in hand with this really, but this is sort of the key thing that I see. It's not so much the pain. When someone comes to see me, it's like, I want to exercise because I'm in pain. Okay, well, what's your barrier for exercising? Well, I'm so depressed and I just have no motivation and I don't like gyms and, I don't want to sweat and, et cetera, like you can fill in the blanks. You've all heard it before, I'm sure. So if we look at like what's the effect of exercise on depression, this is a huge meta-analysis by Felipe and colleagues published in the Journal of Psychiatric Research. And this is after controlling for publication bias. And so we still see a significant large effect favoring exercise, and they've actually included a whole range of exercise interventions. So this isn't just one type of exercise either. Favoring exercise over control. And so this isn't just a do nothing control, because that's actually now considered unethical in research, because we know that exercise is so efficacious. So these controls are, some are wait lists, some are treatment as usual, so they're still on medications, and engaging in psychotherapy. And then these are also educational controls, so it's what we call like attention controls. So these are people that are still learning about, how to manage their stress better and, how to engage in more walking and change their health behaviors. So I think that's actually really phenomenal, but it still leaves us with this golden question, which is like, well, how much do I need to do then to get this amazing effect that I can see with this red dot on the screen? And my answer to you with this is that it actually doesn't take much. So you can pretty much do any type of exercise. So aerobic, resistance, yoga, tai chi, swimming, whatever it is that tickles your fancy, do something that you enjoy typically. And we can see benefits with as little as 10 minutes. So in terms of a dose response relationship, when patients are like, well, how much do I need to do? It's not an hour every day. We're seeing massive mental health changes on measures such as like the DAS or the PANAS, where people are, getting huge effects from as little as 10 minutes. And I know it's the whole national guidelines is kind of where what we hear the most in terms of like, it's your 30 minutes a day, you're moderate to vigorous, but it's also meeting your patient where they're at and actually figuring out what's going to be achievable for them and getting those little wins on the board. Yeah, so this is, I've already sort of mentioned this. It's basically like we have a buttload of evidence and it's just nothing's really happening with it. So this was a perspective piece that was published in a journal that escapes my mind at the moment. But based on this, we actually ran a little study at a conference a few years ago. And actually, you might have been there. If you're a psychiatrist, you might have been there. Maybe even a psychologist, you might have been there. It was a few years ago now, and we basically sat psychiatrists on an exercise bike and ran a submaximal VO2 test. So we basically predicted what's your cardiorespiratory fitness, how fit are you? And then they filled out a short questionnaire that was basically around what they knew about exercise and exercise physiologists and how likely they would be to refer a patient to see one. And what we actually found was that psychiatrists with a higher cardiorespiratory fitness or a higher predicted VO2 were more likely to refer their patients to an exercise physiologist. So it's like you kind of need to walk the walk to be able to talk the talk, and it just makes sense. They've got their own personal experiences with it. They can talk to their patients and engage in those conversations around like, oh yeah, I know you might be worried about this, but it's not that bad. Like this is what it's like. And so it's hard to have those conversations, and it's hard to try and point your patients in the right direction with these behavior changes if you yourself aren't doing them. So I think it is a big broader culture change within allied health and within medicine and within organizations. So I guess my point here is that it's not always putting the onus on the individual, because that individual has like enough on their plate at the moment as it is. So this is Simon Rosenbaum's PhD intervention, which he ran at the St. John of God Hospital. So he ran a randomized control trial with veterans. He had 81 participants, and they went through 12 weeks. It was basically like, if you imagine the Adelaide Clinic, if you're familiar with that, it was a similar situation. There was no EP services set up. There was a small room that they turned into a gym. All the exercises were like with TheraBands or, very, very low tech equipment. So nothing fancy at all here. I'd just like to point out the loss to follow-up. So we see that the retention was actually greater for those that were engaged. It's a very well received trial with some amazing findings that have been published. And I'll quickly go through them here, but we see that so this was 12 weeks, and not only was it effective at reducing their PCL scores, we also see a reduction in their DAS scores, not surprising really. We actually see a reduction in their waist circumference, which is amazing as well. So that's again tapping into a lot of people's goals. And then this is probably my favorite part, is that we are sort of passively increasing their physical activity outside of the clinical trial because they're doing something under supervision with some structure. So their health behavior change in their own time increases. It's that behavioral activation principle, right? So this is really amazing. And there's a whole bunch of data around, like, if we replaced 30 minutes of sitting per day with light intensity exercise, our risk for dying, or whatever the term for it is exactly, sorry, I'm not being super accurate here, but goes down by like 40%. And that's, again, talking in dose response relationships, 10 minutes, we see a positive effect, 30 minutes, we see probably more physiological effects as opposed to mental health effects, but it doesn't take much. So exercise. I want to deconstruct the way we think about exercise a little bit. So assessing and addressing the associations and all the beliefs that our patients have about exercise. And so I think this word often makes people think that they need to be in a gym, they need to be running, they need to be sweating, their muscles need to be hurting, and then that's you're exercising when you are like dying, basically. We've all been there, we've all had these thoughts. But I think the beliefs, particularly when someone's in pain, the beliefs often revolve around like, it's not safe to move, exercise is going to make my pain worse, all exercise is hard, I can't do that, like my body can't tolerate that. So I actually want to just kind of go through, like, yes, exercise is one kind of term that we use, and there are specific definitions here that sort of separate these terms, but I actually find it so much more helpful to use things like movement, because I think it just takes that onus off of it needing to be hard and having all these associations. And it's like, it can be light intensity, it can be inside, it can be outside, it can be by yourself, it can be with your friends. So just getting creative with like language and terminology, and just being clear on what that means for your patients as well. So zooming out of exercise, well, if we look at exercise first, it's things, like running, cycling, push-ups, yoga, treadmill, dance practice. It's these structured forms of physical activity. But if we zoom out and we look at movement, for example, this is all the things that are going to feed into your overall physical function, your quality of life, like playing with your kids, playing bowls, being able to do your own food shopping, being able to get in and out of the car, like walking up the steps without fear of like knee pain for the next 3 days. So it's all these sorts of things that I think are important to people. So if we think that exercise brings certain images and associations to people's minds, you can imagine what the word yoga brings to people's minds. So yoga, as in like the strict definition of the word, literally just means to yoke or to unite. This is an ancient Indian practice. It's been around for thousands of years. Traditionally engaged in, well, traditionally it's actually a combination of a whole bunch of different practices that you engage in systematically to try and reach transcendence or enlightenment or self-awareness, essentially. Nowadays, in our modern Western culture, I think yoga is primarily a form of exercise and stress management. And it's interesting because the correct term, which doesn't get used a lot, especially in the literature, is modern postural yoga. That's what most of us experience. It's the yoga that's very exercisey, movement, classes, asana, that type of stuff. It's actually influenced from military calisthenics, the European and American gymnastics culture, martial arts, and contortionists. And that sort of explains why you see all those really unachievable, bendy social media poses happening, because that's really where the influences come from and what obviously, us in our Western society strive to do. So these are contemporary fitness-based styles of yoga, which do range from light intensity to vigorous, and they typically focus on strength, balance, coordination, and flexibility. So it really does meet the ACSM, so the American College of Sports Medicine, their definition of exercise. So for me, utilizing yoga in clinical care is basically a modern way of saying that we are going to move our bodies through their entire available ranges of motion, which is going to require your strength and your stability. We are going to do this with the intention of improving your clinical outcomes, whether that is mental health or physical health. We're going to have awareness. So we're going to have interoception, proprioception. We're going to notice our reactions to intensity, and when my heart rate starts to rise, how do I narrate that experience? We're going to have an overall sense of awareness of this experience, and we're going to do it in a non-competitive way. And so yoga is really great for that, in the sense that you can't really lift a heavier weight. You can't run a faster time. You can't do it better than the person next to you, because it's an internal experience, all of your own. So if you haven't done a yoga class before and you have really no idea what I'm talking about, they're typically 60 minutes, and you kind of start with some sort of breathing or grounding tool that gets you kind of out of your day and into your body. You'll then move probably for about 50 minutes of that class, and you'll be reminded to breathe properly. So breathe with your diaphragm the entire time. You'll be reminded to pay attention to where your body is in space, to your posture, to your pelvic tilt, to, if you're poking your chin out with your forward head posture, you'll be continually brought back to focus on your body. And then at the end, so it's this sort of constant mindfulness throughout, but then at the end you have this pose called Shavasana, which is either loved or hated. People either get up and leave before it, or they will try and stay for an hour afterwards. But you lay on the floor in what you could say is just a deep conscious rest. So it looks like you're sleeping and you're doing nothing, but you're essentially consolidating the effects of what you've just practiced, I suppose. So if we do actually look at the literature and we look at what research has shown in terms of psychological, and I've skipped over the physiological so much because I think it's a little bit too nitty gritty for what we need here today. But what effects yoga interventions have had. And we see that there are improvements in self-regulation, self-efficacy, interoception, motivation, self-compassion, psychological flexibility, positive affect, and mindfulness. And then actually for some conditions like chronic lower back pain, there have been multiple very rigorous randomized controlled trials conducted, and yoga is actually considered an effective treatment for this. For many other conditions, I would consider there to be preliminary results which would suggest that yoga practice can lead to symptom reduction and can increase function and improve quality of life. But there's probably over 200 reviews that look at yoga on physical health outcomes. But we would still say that there needs to be better conducted studies before we're kind of, claiming this. But we do see, particularly in breast cancer, depression and anxiety, we see a lot of improvements in mental health within these chronic disease populations. There's not too much on the physiological stuff just yet. So the factors that we see associated with exercise intervention effectiveness, particularly within people with mental illness, are the exercise dose. So this is a key factor. So if we're going to get two things with our patients when we are discussing exercise, it is the dosage and it is the qualification of the supervisor. So we see better adherence, less dropout, and better outcomes when a university qualified exercise professional, so an exercise physiologist, a physiotherapist, etc., is providing the exercise intervention. So the person providing this intervention needs to understand the pathophysiology of the chronic health condition that they are treating. They need to understand the effects of the medication, the contraindications for exercise, and they also need to understand that the changes in symptoms might occur independent to changes in things like body mass, for example. So they need to have that broader understanding. They also need to be aware of behavioral activation and motivational interviewing techniques and things like that, because it's not as simple as someone rocking up and, being good to go and super pumped. Like most of the time we're trying to drag these people out of bed and getting them to do 5 minutes of something. So it is a really long process that you do need to be able to see that from the get-go and not assume that the person's just disinterested or lazy and things like that, which I don't think you get that in a personal training course as such. So just a little overview. I think EP is relatively new, and I think there is still a lot of a way to go in terms of understanding what the process of seeing an EP is like and seeing, what the experience is like and how we differ as how we differ from fitness professionals, but where we sit in the spectrum of allied health. Because quite often the first question I get asked is also, you're like a physiotherapist. And it's like, well, kind of, I deal with people's bodies, but like not at all. Like we're very, very different. And I still think that we've got a long way to go. So I'm just going to try and shed a little bit of light on that for you guys today. My quickest explanation of it is we don't diagnose. So a physiotherapist will diagnose. We don't diagnose. We don't do all the little tests as thoroughly as they do, but we look at you more as a whole entire person and your global functioning. And so a physio might treat, you know, your rotator cuff. If you've torn it, they might rehab you for the first 6 to 8 weeks, and then we'll probably grab you and we'll take you through for the next 6 months and make sure that that rotator cuff isn't going to get injured again, and look at your hip and look at why you're getting some back pains periodically and things like that as well. So there are multiple referral pathways in. We do a full initial assessment. So when GPs and when psychiatrists and other doctors and specialists do send through thorough reports, including their goals for the patient, that is so, so helpful for us. Gives us a great background. Quite often as an exercise professional, a patient doesn't think that it's necessary, and nor do they want to disclose a lot of their medical information to us, particularly around their mental health. They just think that it's absolutely not relevant. I don't need to know it. It's not going to affect what I'm going to do with them. Yeah, cool. So a little case study here. So this is a patient that I've seen at the Adelaide Clinic who Nick suggested would be a great example. So, and no, we were talking about it before, you haven't told the group. So I'll give you a little brief overview. 40-year-old male, he served in Afghanistan, performed extremely well, diagnosis of PTSD and then subsequent substance use disorder, had a cardiomyopathy, which then resulted in a fear of exercise, obviously not wanting anything bad to happen from that. Musculoskeletally, had an MRI with L4, L5 disc degeneration, but no surgery required. Mild intermittent low back pain, you know, a tibial osteotomy, had an arthroscopy on his knee, you know, considered arthritis in both knees, mild discomfort with loading. That was a key thing for him because he really enjoyed running, and running was a coping strategy that helped his mental health, but he couldn't do it because his knees hurt. Yeah, so his goals were around reducing weight, improving his pain, and returning to running. So I saw him in the Adelaide Clinic. Now the Adelaide Clinic's a very different scene to seeing an EP in a private setting. But with him, for example, it was as quick as looking at so for his goals, it was like looking at his squat assessment. So how does he move all the joints in his body at one time? You know, he's going to sit on the toilet, he's going to sit in the car, he's going to sit on the couch. And we hold tight. So we looked at retraining some movement patterns. Did I put these in? Yeah, so we looked at his squat pattern. We looked at where his center of gravity was sitting relative to his hip, knee, and trunk angle. We looked at his hip internal and external rotation because like he had this intermittent low back pain, which was giving him some grief. And we looked at his spinal flexion and then anti-flexion, so his ability to resist flexion. Yeah. So essentially his core strength. Gave him 3 very simple exercises. Now this is all going to sound quite jargony to you, so I apologize. So this was assessing his squat, right? So the little dot is center of gravity, and you can see whether your center of gravity, I'm tempted to all make you stand up and try this. Yeah, stand up and try it, come on. Because then otherwise, you know, you're not embodying it and you'll just get sick of my voice. So stand up, take a nice comfy stance. Now you don't need much room, just make sure if you stick your bum back, you're not gonna touch anything. And then I just want everyone to squat down as low as you comfortably go in a way that feels natural for you. That is a great squat. There are some great squats in here. Stand back up. I'd kill for that squat. Cool, do it again. This time I want you to pay attention to where you feel your center of gravity is. Is it at the back of your foot? Is it in the middle, or is it more in your toes? More in your toes, yeah, cool, come back up. So you don't have to hold it down there for very long. Now I want you to go down again and just change your center of gravity once you're down there. Like put it at the back, put it at the front, and figure out where feels more natural for you. Yeah. And notice, like, did your heels lift? Are your feet turned out? Are your feet really wide? Was your trunk like parallel to the floor, or were you quite upright? So these are all the little things that are going to change, you know, the torque on the muscles and things like that. You guys can have a sit down if you want. Thanks for being my experiment. But it's just like something as simple as that for him. It was just taking the center of gravity back a little bit. And then he was like, oh, I feel no strain on my knees now. So now I can do my squats and my lunges and all these things to strengthen all the muscles around my knees, which is going to help me feel like I'm achieving something back towards my goal of running. It's also going to help with his back pain. So little windscreen wipers, these are great. You guys should, everyone should do these. We don't move our hips enough. Like hips are rotational joints and we just like literally don't rotate in our modern life. It's really sad. I think quite a lot of back pain would clear up if we did more rotation with our hips. So laying down like this on the floor, you literally just windscreen wiper your knees side to side. So just getting your femur rotating in the acetabulum, getting some internal and external rotation. He did that. He felt amazing afterwards. That was great. I said, if it feels good, keep doing it. If it doesn't feel good, stop doing it. And then we had him doing a forearm plank. So this is just an example of some postural things that we're looking for in a plank. Quite often what we're going to see is the guy on the right, people not being able to like support their cervical spine, being very kyphotic because we just passively sit in that range all the time, and then having really poor lower abdominal control and probably actually not very good even flexion through our lumbar spine, which a lumbar spine is made to flex. It's not made to rotate. Your thoracic's made to rotate, like your rib cage is made to rotate. So if my lumbar spine isn't flexing, my thoracic spine isn't rotating, well, I've got to compensate this movement somewhere. Of course, I'm going to have back pain. So we're just starting to address these things and just trying to get a little bit of neutrality back through his spine so that he can, move better throughout life. So this isn't rocket science. It's very simple. It's very basic. He probably walked out feeling like I hadn't really given him much. And I didn't see him again, but we did hook him up with some EP services in back where he's from. And I've heard very good things from Nick, and Nick says he's doing amazingly well and he's just loving it. So he's a great case study. Ideally, I would see him again in 3 to 6 months, and I would be able to run like a reassessment. So I would measure things like, his blood pressure and his waist circumference and any cardiorespiratory changes. Can he exercise at a certain intensity, but it feels easier, it's more enjoyable? What's his heart rate response like? And neuromuscularly, I'm a little bit different to most EPs. Like I'm not a huge strength and conditioning EP. So I don't really do a lot of strength tests, but it's a really common one that we do. But I'm looking at things like, is your movement quality improving, and is your movement efficiency and speed and ease of movement, are all of these things improving? Because then you're going to move through life and life's going to feel a whole lot easier for you. So my take home messages are, there's a physical health disparity. We need to break down how we think of exercise, and we don't need to tell people to do much. Something is better than nothing, but we do need to look at providing evidence-based, individualized interventions that can address pain and address musculoskeletal conditions. And, by courtesy of that, address people's motivation, which is a big thing. And culture change is required from the top down to normalize physical health treatment as a part and parcel with mental health treatment. These two things need to go together. Thanks. Yes.
Just so those online can hear.
Sorry. Losing weight's really hard, takes ages and discourages people, but you've mentioned you'll see an improvement in VO2 fairly quickly. How easy is that to measure to kind of motivate our patients a bit more that something's happening?
It's pretty easy to measure. 16 minutes on a stationary bike with, everything sub max, and we just basically base your workload based on how your heart rate responds. So it's all absolutely able to be done.
Excellent.
Any questions online? Any further questions in the room? Yep, at the back.
I was just going to reinforce what you said, Jacinta, about yoga and its impacts on health. We did a study at the REPAT a number of years ago now with Dr. McCarthy, and they measured sleep. They did a whole lot of mental health measures, as well as they would hook people up and look at their cardio and a number of other areas. And the patients involved had significant chronic PTSD. I think most of them were Vietnam veterans and had been in acute care for a period of time, and their health on all measures improved dramatically. And most of them continued yoga practice long after the study. There's another study underway at the moment at Jamie Larkham, which is looking at trauma yoga and the use of it for staff and patients. So it'd be great to get the findings for that one as well.
Really cool. Yeah, I think staff's a big aspect that needs to be addressed as well, because we're doing all these interventions and we're getting all these good results, but then at the end of the day, like if the staff culture doesn't change with us, then we're not going to be able to feed that down. But yeah, cool. Thank you.
Any further questions?
No. Cool.
Okay. Thank you.
Afternoon. I am mindful of the time, so I'll try to speed up my time slot. I am the last speaker for today, so just bear with us for a little bit longer. And I'm pleased that Jacinta got us all to stand up and move. I was going to offer the same thing. But the other point that I was going to raise is pretty much all through today of all of the speakers, it's as if people are speaking about me. And I'll give you a bit of context to that in a moment, because when we think about case studies, it's probably really fitting that I come last, because I'm going to probably, in a sense, show you one of the thousands of people that we've heard the statistics from Miranda this morning as to what this looks like, I guess, maybe in a physical body. So my name is Matt Newlands. When I was 4 years old, I wanted to be a police officer. And then when I was 20, I became one. So then if you imagine that for a 10-year policing career, when I finally found myself out of service in 2016, policing had occupied 27 years out of 31 years, either as a dream or as a reality. That's a pretty significant identity. When I do my presentation, I'm going to condense what would normally be 45 minutes into about 15. I'll do my best. I do talk about the fact that I joined the police looking for an identity. I was 20 years old. I walked into the academy. I was taught very quickly that emotions aren't necessary. The only emotion that is effective is anger, because it motivates us to do things. So my measure of success throughout my police career then was the less I feel, the better I am. It works well. It's actually a model that works really well. It keeps me safe when I'm out on duty, keeps my teammates and colleagues safe as well, and allows me to fulfill a social obligation. When we think about like a human being being put in a position of fear, and we start looking at the fight, flight, or freeze response, in essence, the academy trains us to operate off of one, which is fight. Now, I know that there's going to be some service members, and I'm looking at a starry at the front, that is going to be thinking that even this tactical withdrawal is actually built into our model. When you might say, well, withdrawal, how can that be tactical? The reason why they call it tactical is because it's still our problem. We don't get the ability to step out and to run away and hide, where maybe then a threat for others, they are allowed to do that. And sometimes I think when I do some of the workshops that I get to do at Measure, and I'm telling people that in the case of emergency, assemble here, I know that I'm lying, because in the case of an emergency, these are the people in the room that are going to stand up and do something, because ultimately that's what they're trained to do. When I joined the police, I went to, where did I start off? Sturt first, went to Port Augusta. I got sent there. So immediately I felt the impacts of, I guess, the social isolation, because all of the friendship groups that I had back here in the Metropolitan area were gone. That being said, I did have a family when I arrived in Port Augusta. They were all wearing the same uniform as me. Further instills that sense of identity. I came back to Christie's Beach and I spent most of my career down there. I did mostly general duties or frontline policing roles, lots of shift work. I enjoyed that stuff. I then went into some plainclothes investigations. So I got to do some low-level drug crime, outlaw motorcycle gangs, that sort of stuff. And that was the stuff that I really enjoyed. Because I enjoyed it so much, I then was fortunate to be selected for a position at the State Tactical Response Group in 2015. Now, if we go back 18 months, a friend and colleague committed suicide whilst I was on duty. So you imagine the impact that it has now that not only is this my friend and are all of the people around him my friends and colleagues, I have a job to do. The job always comes first though. So there's no time for sadness, there's no time for shock, grief, frustration, anger. It's just time to do work. We start talking about the moral injury stuff. I then start to wonder, what's the point if this is how this ends? Over that 18-month period to 2015, I embarked on significant risk-taking behavior because now I was starting to try to feel again, feel something. So I was the guy that if I put the lights and sirens on, I was hoping you would run from me. I was the guy that if I went to a hotel and we saw the biggest, ugliest, meanest, drunkest dude, that was the guy that I was going to try and hope that he would fight back. I was looking to feel something. In January 2015, I recognized that something wasn't quite right with me, so I went to a doctor. Doctor referred me to a psychologist. Psychologist told me that I was showing symptoms of severe to extreme post-traumatic stress and depression. I said, that's bullshit. I've never been to war, so post-traumatic stress isn't mine. And I don't feel anything, so how could I be depressed? The following weeks, month or so, was him trying to show me that my brain activity wasn't operating maybe the same way as a normal person would. And that when I closed my eyes, my brain activity increased rather than maybe decrease, which kind of explained why I was using probably a bottle of red a night to go to sleep and having about 2 to 3 hours of broken sleep. That was just to hope quell the nightmares. But I also found that by drinking red wine, it felt like I wasn't an alcoholic because it felt a little bit more gentlemanly. I wasn't the jaded detective that you'd see staring at a TV that's not turned on, drinking straight whiskey. You know what I mean? Like that guy. I wasn't that. I was the guy. I lived in the Fleurieu region. I was drinking red wine. That's what we do. Unfortunately, it was a perfect storm, coincided with my move to the State Tactical Response Group, where again, I uprooted all of my work colleagues, because by that stage, when you think that I've been in for a few years by now, I didn't have any friends outside of the police. And now I had a new community that I had to prove my worth to. I had to show them that they could not only trust me to keep them safe, but they could trust me to keep myself safe so they didn't have to worry about me. So there's a lot of that cultural stuff that goes in. There's not a chance in hell that I was going to say to them that I'd just been diagnosed with post-traumatic stress and depression. If we fast forward to the 7th of August, 2015, I had considered to take my life on 2 separate occasions. I had completely isolated myself. I had the means to do it. I had access to a wall of guns and drawers full of ammo. And I felt as if I was completely isolated. Not only that, I found myself in the city watch house having been charged with theft. Made a pretty foolish decision to steal a baseball bat. Some here now going, that seems crazy. Why would you throw your career away for a bat? I like to say I got my life back because of a baseball bat. Because had it not been for that, I'd be dead. Doesn't say that it was necessarily an easy path. From August of 2015 until May of 2016, I then went into this space of not only being pushed out of SAPOL, but the Adelaide Magistrates Court decided to convict me. SAPOL went for a custodial sentence. Felt a little harsh, but that's okay. I take it at this point that is where I say I'm not anti-SAPOL. We've got lessons to learn from my experience on one story out of thousands, and many of them have had good experiences. There's people in the room that can help contribute to what those good experiences might look like in the future. In 2016, I found myself now either not necessarily wanting to die, I wanted to actually live a life of meaning and purpose. But I didn't quite know how to do that because I'd only ever known policing. And this is where some of the emotional regulation stuff comes into play. If I was going to define myself as a new person, as a new man, and how I was going to do that, I had to learn how to feel again. I had a wife and daughter, thankfully, that hung around. I gave them plenty of reasons not to, but they chose to stay. My daughter's now 10. I certainly connected with a lot of stuff Karen was saying. I was actually thinking about that on the way here, listening to an audiobook going, man, I'm a really shit dad. Working on it. In 2018, I was made aware of the STARE program at the road home. I didn't even know the road home existed until a friend said, I'm doing this program. I said, what's that? He told me a bit about it. I found myself doing the program. I had done probably about 18 months of my own self-help, if you like, and trying to reconnect and learn something. And then stumbled across the road home and the STARE program, which is now the GEARS program. I saw that it worked for me, felt connected. It's the first time that I'd started to recognize that I was back in community again with emergency services members. So that was huge. But it also started to explain to me that one, I wasn't the only person in a similar situation, but two, this was going to be a forever thing until we started making a change. Now, because I'm a service member, I'm here to do stuff. That's why I do stuff. Now I do the program, still doing. Good part about it though, is that over the last little while as a volunteer is where I first stepped in and under the leadership and guidance of Jon Lane, I then started to get an exposure to how to learn how to facilitate the program. And then at the end of last year, when the road home became Measure, which is this fancy little logo that you'll see plastered over everything, particularly the shirts and things, I was tapped on the shoulder and asked to get involved in a bit more of a formal capacity rather than trying to navigate full-time work plus then volunteering with the road home as well. So really, really grateful for that opportunity. The reason why I say all of that is because as I was telling my story, you've probably connected in with a stack of things that our previous speakers have spoken about today. A lot of the stuff around identity. My wife and daughter aren't here today. They're probably going to be calling me soon to find out where I am. But I did message her and said, you should be here and you should probably be presenting. She still refuses to do that. We'll break her down. The key word that's up there at the moment that you'll see at the top is lived experience. And it's a term that's probably you've all heard many times before. And I think it's still something that from Mesher's standpoint, certainly from my standpoint, that I'd like to put a bit of substance to. You've heard a bit about my story and there's a lot more to it. But the term lived experience is not about just necessarily having a story. For us and for my workforce, it's about having a story, but then navigating those challenges to a point where there's either strength or recovery or whatever word you want to use to put all of that experience to good. It's not about just still being in that space. And I think that sometimes can get lost. The other important point to make about the programs, and we've heard it already, is that being transdiagnostic. Every person that's come into a GEARS program, and we've just had 3 programs kick off last week, we've got a couple more that go next week, pretty much everybody in the room has said, this program's not really for me, but I reckon I'll be able to contribute something to the group and others that I can help. I was like, I don't care why you come in, I just know you need to come in. But it's a pretty common story. It's that disconnect from self and wanting to help others. But there's a whole range of reasons why it brings them into the room in the first place. The other thing that we talk about and we have spoken about is it being a functional skills-based program. We recognize that everybody in these groups is likely going to have issues with sleep, for example. Doesn't necessarily mean that our focus is on sleep. We look at other techniques such as the grounding, the mindfulness, sleep hygiene, all these different skills and tools and strategies that they might be able to use. So when they find themselves unable to sleep, they've got a toolkit they can then go into and start unpacking some of this stuff. One of the guys that's just started out in the GEARS program, he said to me on Tuesday morning, he goes, when I've been told by my doctor that when I'm feeling like shit, I need to go outside and look at the birds. And he says, now I go outside and I'm staring at the fucking birds waiting to feel better. Context is important. So what we try to do is we explain why he's looking at the birds. And maybe birds isn't his thing. One of the other points as well that we put on there is around it being a collaborative approach. It's really, really important for us to highlight the importance that you all play in various health professions in these individuals' lives. This is not a lived experience versus clinician space. This is not this health professional versus this health professional. It is us and you. It has to be a holistic approach to the well-being of these individuals, because some of the people that come into the programs are saying, should I tell my psychologist this stuff? And I have no doubt that when they're going to see their psychologist, I know that sometimes they're taking the workbooks that Jon spoke about in the GEARS program, they're taking it with them because it's helped give them some way of articulating what's been going on for them. So when they do come in and they find this space of what's wrong with you, or then they say, I don't know how to answer that, so maybe there's nothing wrong with me. We're starting to give them a way in which they can express what is actually going on. And this is also another way that we can break down some of that stigma around they don't get it because they've not had service. I think that's wrong. Yes, there's certain elements that civilians might not understand, but it doesn't discount the experience and the skill set that you as the health professionals bring into that space. This is why it's really important for us all to be working together. I'll touch quickly on the GEARS program first. Group-based, 8 to 12 people in the room. It's designed and led by peers. So you've heard John, he's designed the program. People like myself, we lead the program. The important point about that is that everybody in the room has had a service background or maybe still is in service. So for example, one of the lead facilitators on a Tuesday morning is a full-time current serving Metropolitan Fire Service member. MFS have allowed him to come into our space and deliver the program. We've got Air Force members, we've got ex-police, we've got myself. There's a stack of us that are now starting to upskill and learn. The other good part about the program is that we can start to recruit from the program the next generation of facilitators. And I'm a perfect example of that. I did the program in 2018. I said to John, I want to do more. He said, no worries. Start doing. Gave me a practical pathway to get here. I'm now qualified as a counsellor and I'm now able to deliver the GEARS program. It is a 12-week program, 2 hours face-to-face each week, and then there's homework between. One of the bits of feedback that I got from a participant on Tuesday was that he said, I have taken away more in the one online Zoom session and one group session that we've had than I have in the last 9 months of the help that I've been trying to seek. Now, I don't necessarily say that that makes the program better than the 9 months before. There's a good chance that 9 months has helped him get into the room in the first place. But what he did find is that he had a community and everybody was nodding their head when he was sharing some of his stuff. The first 6 weeks of the program is a focus back on self. Session 1, we start to talk about how we got to this point in the first place, the trauma, the chronic stress, the maladaptive coping strategies, why it is that we find ourselves in the room in the first place. That gets everybody on board to go, no wonder I'm fucked. Well, you're not. It gives a bit of an explanation as to how we got here in the first place. We then reintroduce emotions. What are emotions? I can tell you that every time I ask the group, I've done the groups probably now about 15, 16 times, when was the last time you felt happy? The room is silent. When I ask them when was the last time they felt sad, it's a robust conversation. I think we can often in service attribute a lot of the negative emotions or perceived to be negative emotions are often easily at our disposal, but the good stuff, not so much. What we like to do though, is to not put this black, white, good, bad stuff around it. We like to start talking about them as what are they trying to tell us? Why do we feel sad? Why do we feel happy? Those sort of conversations. We then continually build on that to the point where we start offering up coping strategies and different techniques that they might be able to use to help sit with those emotions rather than suppress them. We want them to lean into it and to feel it, understand why it's showing up so that they can do something with it. The next 6 weeks of the program is how then that individual plugs into all of the relationships around them. That could be in their existing workplace, could be at home, could be with their children, but understanding that to try to break that narrative around, well, service broke me, this is how I am, everybody needs to get used to that and learn how to manage me. We challenge that to say, well, what can we take responsibility for and how can we best then step forward and start creating healthy relationships? 2 other programs that we deliver, Mind Right and Story Right. Mind Right is a one-day workshop that starts to unpack identity. We start to get the individuals thinking about what their life or who they actually are if service wasn't involved in that, rather than trying to frame it as though service created them for who they are. We start to go the other way. Maybe they're just really good at their job because you had all of those values and all of those qualities about you in the first place. Maybe that's why you were drawn to service. So how can we then find or connect back in with that higher purpose and find that maybe outside? Or at least understand where service fits into your identity. Story Right is a one-day workshop that focuses specifically on the skills, qualifications, and experiences that might translate into the civilian workspace. So what we often see is that people come to Mindright first. They start to think about who they are, what they want to be in life. Maybe service fits in that, maybe it doesn't. And then the workshop, maybe a week later, they can start mapping out their career pathways in the civilian workspace. Intentionally, these programs are delivered off base. Intentionally, it's in casual attire and no rank as best as possible. We're starting to get people to try to think outside of that structure. I think that John mapped out for us so clearly. I can see that in every service. The future for our programs, and I think I touched on it for those that were here last time, so we are building a peer workforce. That's our intention. We know that there's many service members who are either being pushed out or they're choosing to leave, and we're trying to find a connection back into being of service. And often they're drawn to being of service to other colleagues who might still be in service or have had similar sort of experiences. We're trying to create an opportunity for have a safe place to land, and then they can find purpose in their service in delivering some of the programs that we have. We're also asking GEARS facilitators to be qualified counsellors. Why would I not then try to put them to good use? There's also a number of programs that we probably don't even know about yet. We're still working on about 35 projects that are likely to develop more if there's any more gaps in the area. And if people are still sitting here going, you still miss this gap and this gap, then come speak to us, let us know about it, and maybe we can start researching it so that we can develop a program if one doesn't already exist. We do have an intentional focus on families as well. We've heard about Karen's program. And like I said, there's more than likely going to be more stuff out. We're also working with the RSL, with Soldier On, with Open Arms, and any other ESO that wants to sit down and talk with us about what programs they offer. So we don't look at just reinventing the wheel. We can look at supporting those other programs and then help refer people over to that way as well. I think I've condensed it pretty quick, because I know everybody's like, I just want to go home. Take a picture of that if you want to. Otherwise, I do have some business cards at the end. If anybody wants to speak to me about any of the work that Mesha is doing, you want to start sending people through for GEARS, Mindright, StoryRight, by all means, let us know. Thank you.
I was just going to also give a mention to another program that someone else asked me about earlier, was services for the children or the family members. There's a program that we're about to research. We've been running a program of trauma psychotherapy specialising in somatic and art therapy techniques, and that's been offered to service personnel with PTSD. We've now expanded that program this year to include children, and that can be any age. They can be adult children of a service member, any family member, and the practitioner also sees the whole family. So often it will start with engagement with the children, and then often the parents, whether they're together or separated, will start to engage in the counselling process as well. And she's having really amazing results working with the families. So that's one, that's free. I mean, military members can access Open Arms, but for emergency service personnel, a free counselling service is really valuable for the member or the family members. And the other program I was going to mention you may have heard of is Invictus Pathways program. It's a program we established a number of years ago, and we have now, it's run, we fund it, but it's run through UniSA. Fabulous program, which works with basically physical health, but really big aspect to it is the social integration. And you know, there's activities, physical activities that are run, and they do come and try days, come and try archery, come and try kayaking. Sometimes it's a day that's directed at the member and family members. Other days are specifically to sort of build a bit of a community around the veteran or the emergency service person. They have linkages with gyms and free access to NextGen on certain days. It's a brilliant program. They offer podiatry, physiotherapy, physiology, OT, and I think now psychology as part of the program. They help individuals set goals. So there is opportunities to engage in Invictus games, and many of the athletes that have engaged in the program never envisaged that they would go to an Invictus Games, but did. And also there's other local competitions, Masters Games and Warrior Games in the US and other competitions, biathlons. We've got hope for that in the future. Yeah, so great programs to get engaged with and get people out from home, particularly if they've come from interstate and they don't have the connections here. It's a great way for them to meet other people.
Thanks, Karen.
Okay, we've got a question. And those online, please feel free to type questions in the Q&A. Thank you.
Hi, Matt. My name's Louisa. How are people referred to the GEARS program? Is it usually GPs or psychologists?
Yeah, either. So a health professional that usually the service member would probably be connected in with anyway. If you do go to mesha.org.au and you look at the programs, there's a GP referral form that's on there. It does say GP, but health professional, I think is probably the best way to put it. It also outlines the eligibility criteria, which is basically if you're ex or current serving and experiencing some type of mental distress as a result of your service. Yeah. No, I think that's the other important point. Yeah.
Just reinforcing, as Matt said before, these programs are adjunctive. Yeah, so just for the people online, yeah, these programs are adjunctive. And so we, again, wanting to work with clinicians, this is just another area where we're providing services. But, you know, having people with lived experience and having a functional sort of approach, it makes a big difference. I'll just, Stacey, I'm going to just grab you randomly. What your experience of people you've referred to the GEARS program?
I thought I'd gotten out of public speaking today, but apparently not.
Stacey Bell, ladies and gentlemen.
Hi. Wash my face now. So I'm a psychologist. I work a lot with Nick and Denise helps me out a bit as well. And yeah, certainly I volunteer with the Invictus Pathways program and just can see how beneficial that is for people to find their tribe and be connected and really be able to participate in something that's really healthy for them. Really, really valuable program. What else? GEARS.
How do you find people go on the GEARS program? How does it benefit you as a clinician?
Oh, yes. So people definitely bring their book in to sessions with me and we can run through homework and particular topics that they might be struggling with in the program as well. One that springs to mind for me is radical acceptance. We know that can be a bit of a tricky one, but certainly, yeah, again, that idea of being with people that they can, you know, like-minded, connected with, understand their experience is super beneficial. And, you know, they've got tips that I don't have to necessarily go over because they've done it in the group. So that's helpful too.
Thanks, Stacey.
Yeah, I would just like to reinforce how positive I find my clients participating in GEARS. Just like what Stacey said, people bring in their books. I can think of a particular police officer and he takes that book everywhere. And when I ask him about a particular challenge or something that I've asked him to do, he will open the book and go, yes, well, I've done that. And just as it says in this book, and then I got stuck with this and I went back to this part in the booklet. So that's really, really helpful. I'll also say that there's certainly been enough of my clients that have gone, oh, look, thanks very much, but, you know, I'm not a group sort of person, you know, not really interested in that. And what's been really helpful is that people who have been on the course are quite willing to chat to people and just give their experience of it, which is far more powerful than having your psychologist say, oh, look, I think this would be good for you. And I can only think of one person in the years that it's now been going that has said that they didn't like it. And that person actually didn't go very many times. That person just really didn't give it a go. All these people that had been saying to me, oh, look, you know, I really trust you, but no, thanks, you missed the mark here, have come back and said that was the best thing for me.
Oh, thanks, Denise. I think it is an important point around that group dynamic. It's intentionally in a group setting. We're trying to break that social narrative around like doing this in isolation. We're letting them hear from their peers and colleagues and we've had commissioned officers in our programs as well. That's another little challenge that we have to navigate. But so far, those commissioned officers have been able to, they've got their own stigmas that come with being in a high ranking role and knowing people in the room that might be their subordinates and vice versa. We have people then, why is that person in the room? But to hear it, we start to put a human behind it. We're taking away the uniform and we're just seeing a human who's experiencing distress and is trying to navigate that. We're giving them some tools and strategies on how to do that. Yeah.
Nick, can I just ask, is there much of a wait list for the programs?
Yeah, usually, yeah. Our biggest barrier to growth is the amount of facilitators that we've got as well to deliver the programs. And the reason why I call that a barrier, it's again, we have to be really careful about who we put into these positions and make sure that they themselves are ready to be in that role. And there's really sort of 3 fundamental pillars to being a facilitator. And one of them, I guess, is, you know, being able to facilitate a group of people, just as that's a standalone skill set in itself. You've got 12 people who are all in a room wanting to maybe share some of their war stories. And this isn't the environment for that. This isn't a group therapy session. This isn't, we need people who are skilled enough to be able to put a stop to that. Secondly, then we need content knowledge of the program itself, which previously has only been able to be attained by just doing the program multiple times. Now, John and I have worked on some online resources that we're now able to provide to upcoming facilitators so that they can watch the 2 of us, mostly John, do the talking about what the message is for each particular week. But the third part is then making sure that we've got an appropriate accreditation structure, that they have the skills as well. And at the moment, that is the Diploma of Counselling. And so we're referring people to ARPC. However, all of that being said, I would strongly encourage people, like if you do have people you think would be suitable for the program, please send them through to us, because I think that will also allow us to put forward a stronger business case so we can start getting some other military and emergency services members trained up so that we're able to then start delivering more courses. Yeah.
Any further questions?
Sure. Yeah. Everyone wants to go home.
No.
Thanks heaps for your time. Appreciate it.
And well, with that concludes today's workshop. Thank you all very much for attending. There are some flyers from Mesha up the front, as well as I believe Karen at the back has some business cards as well. And if you do have any further requests for information, please don't hesitate to contact us at me, and we can connect you to the presenters or the team at Mesha as well. A reminder to those online as well as in the room, please take the time to complete the evaluation forms. Your feedback would be very much valuable to us for future education sessions. And again, thank you, and thank you to those online. All right. Thank you.